Let's hear it one more time for them. All-woman steel pan movement, providing premium entertainment to local and international clients. I'll tell you a little bit more about them as they will be performing for us later on. But thank you very much, ladies, as we get ready to launch the 14th annual National Health Research Virtual Conference, NHRC, under the theme, Taking Responsibility, Our Health and Wellness in Focus. Welcome to the AC Hotel, those who are here in person, those who are joining us online. It promises to be an exciting, people hear research, they don't know how exciting research is. I'm not going to say it can be. Last year, I was here for the opening ceremony, and I stayed all day. I did. Because I found a lot of what was being discussed to be so fascinating and so important, as it raised questions and issues and offered solutions to many of the things that we face across the region, the world, and importantly, here in Jamaica. So welcome, welcome. Thank you so much for being here and for what promises to be another exciting couple of days. Of course, before we begin, I'm going to ask you to stand for the playing of the national anthem. Ask you to remain standing as I invite Ms. Takis Foga, Director of Health Promotion and Education at the Ministry of Health and Wellness, to deliver the invocation.
Let us pray. Father, how grateful we are that we're here today, this day that you have made. We are so glad and we rejoice in it. We thank you, Lord, for this opportunity to be here together in this fashion, Father, online and in person. Lord, it is your desire that our health prospers. And so, Lord, we thank you for this opportunity that we will have to learn more about the ways in which we can improve our health. We thank you for every researcher, mighty God, for their time, their energy, their effort, their endurance, mighty God, in seeking out information, Lord, that will help to enrich us, empower us to make better decisions, Lord, and even just to know more and to understand this area, health and wellness. Lord, we thank you for our Honorable Minister, our Chief Medical Officer, Permanent Secretary at the Ministry of Health and Wellness, for their continued endorsement and support of initiatives such as these, Lord God. We thank you, Lord, for the planning committee who have put so much effort and measures in place to ensure that these 3 days will be executed successfully. We pray for the judges, we pray for the presenters, mighty God, everybody who has any part to play, Lord God. We ask that you just touch and bless them right now. And we pray at the end of the 3 days, end of each day, Lord, that we would really leave here feeling very enriched, Lord, and ready to make changes in our lives and to help to promote these key messages that we will get from that which is shared. So we give you thanks. Bless all the proceedings, Lord. Let it go according to your will and to your plan. In Jesus' name, amen.
Thank you, Ms. Vogue. Everyone, you may be seated. Well, you heard her say judges, and you might be wondering, what is that all about? The National Health Research Conference is a significant forum for showcasing a wide range of medical, biomedical, and scientific research that can be used to improve policy and practice for the ministry and wider public health system. As we said earlier, the theme for this year's 14th staging is Taking Responsibility, Our Health and Wellness in Focus. Can you say that with me? Taking Responsibility, Our Health and Wellness in Focus. So the conference will highlight abstract presentations from areas relating to mental health, non-communicable diseases, reproductive health, technology in health, and climate change. The three-day conference will also feature engaging guest presentations and robust panel discussions. And I can tell you, the panel discussions tend to be very robust around relevant topics, including telemedicine and health, oral health and NCDs, and digital health. So we have 3 exciting days lined up for you: cutting-edge research, feature presentations, and panel discussions. Over 30 researchers will vie for prizes in oral and poster presentations. So please make sure to view the poster presentations in the poster hall and leave questions or comments for the authors. Now I invite our Chief Medical Officer, Dr. Jacqueline Bisesa McKenzie, to deliver the official welcome.
Master of Ceremonies, Ms. Delia Harris, Dr. Joy St. John, Executive Director, Caribbean Public Health Agency, who I believe is online, Mr. Ian Stein, Pan American Health Organization, WHO, Jamaica representative, representing Jamaica, Bermuda, and the Cayman Islands, Ms. Ade Ashekum, Acting CDC Country Director, Jamaica and Caribbean Regional Program, U.S. Centers for Disease Control and Prevention, Dr. Wayne Henry, CD, JP, Chairman and Director General, the Planning Institute of Jamaica, Directors of the Ministry of Health and Wellness, team members, members of the media, ladies and gentlemen, good morning. It is my great pleasure to welcome you to the 14th Annual National Research Conference. This conference is a milestone achievement for the National Epidemiology Branch, and I commend the team for successfully executing a meaningful event annually. And I really want to ask Dr. Webster Carr and Dr. Grant to stand, and other members of the EPI team who are here, and for us to just give them a round of applause just to demonstrate our commendations. Thank you. The theme for this year's conference, Taking Responsibility, or Health and Wellness in Focus, highlights a key component that is important in modern health: the need for the population to be accountable and to realize that health is primarily a personal responsibility. Over the years, the ministry has championed this ideology, and I'm sure our minister is going to speak about this more, and have designed plans and programs in a bid to galvanize and educate Jamaicans on the benefits of actively seeking to live a healthy lifestyle. The ministry believes in the science and its impact on healthcare delivery. This conference creates an environment for reflection and sharing of scientific knowledge and experiences with the aim of creating a more resilient healthcare system for the people of Jamaica. Collection and analysis of data that is representative of our population will pave the way for relevant and effective policies, even as the country is confronted with new and emerging diseases, to which our cadre of healthcare professionals must respond in a timely and efficient manner to safeguard the nation's health. As has become the norm, I look forward to the presentation of abstracts and ideas that will be put forward at this year's conference. I want to congratulate again and offer encouragement to all our researchers who have sacrificed and offered their time and effort into preparing and submitting their works on technology in health. And it's not an easy path, I understand. NCDs, mental health, reproductive health, and climate change. The outputs from this conference will only strengthen and improve the Jamaican health system as we seek to provide adequate and quality care to all. I hope this year's conference can take us closer to realizing this vision. Once again, my congratulations to the team and the partners on their hard work and dedication to make this year's conference possible. Welcome, everyone.
Thank you very much, Dr. Bisesa McKenzie. And it's important that today we also recognize Geographic Information Systems Day, yes? Because that's something that we have learned over time is very important to us as we do programs and policies in the Ministry of Health and Wellness. Now, our next two speakers will be joining us online. First, we'll be hearing from Dr. Joy St. John, who is the Executive Director of the Caribbean Public Health Agency, CARPA. Here's Dr. St. John.
Thank you very much, Madam Mistress of Ceremonies, Ms. Delia Harris, Dr. the Honorable Christopher Tufton, Member of Parliament and Minister of Health and Wellness, Mr. Ian Stein, Pan American Health Organization, World Health Organization representative, Ms. Adeliku Asikun, Acting CDC Country Director, Dr. Bisesa McKenzie, our Chief Medical Officer, Dr. Wayne Henry, Chairman and Director General of the Planning Institute of Jamaica, Dr. Karen Webster Carr, Principal Medical Officer, National Epidemiologist, and the very capable Chief Cook and Bottle Washer of this important conference, Mr. Kisi Foga, Director, Health Promotion and Education of the Ministry of Health and Wellness, researchers, other invited guests, other Ministry of Health and Wellness officials, members of the media, ladies and gentlemen, good morning. I am immensely delighted to be here today, joining you once more to inaugurate this momentous event, the 14th Annual Jamaica National Health Research Conference. As we gather under the theme, Taking Responsibility or Health and Wellness in Focus, I am filled with a sense of optimism, buoyed by Jamaica's strong role in shaping a healthier future for our Caribbean region. This conference comes on the heels of the Regional Consultation for Caribbean Moves, held in October here in Kingston. CARPA member states from across CARICOM came together focused on the creation of a regional supportive environment to get people moving and placing health and wellness as a top priority. The Caribbean stands at a critical juncture where the challenges we face in ensuring the well-being of our communities are becoming increasingly complex. From the persistent threat of infectious diseases to the rising prevalence of non-communicable diseases, alongside the steady loss of our healthcare workers. Our healthcare systems are under immense pressure. Yet, amidst all these challenges, I am here to testify that there is a uniquely Caribbean, unwavering spirit of resilience and innovation that permeates our region. We have a long history of surviving hardship, overcoming adversity. I only need to look back a few years to the worst days of the COVID-19 pandemic to recall the CARICOM solidarity, which allowed us to survive what was predicted to make our health systems crumble. I am confident that we can rise to meet the health challenges of our times. The Jamaica Health Research Conference is a testament to the spirit of collaboration and shared responsibility for our collective health. This gathering brings together an impressive array of researchers, experts, and stakeholders, united by a common goal to advance knowledge and drive evidence-based interventions that improve the health and wellness of Caribbean people. Your theme, Taking Responsibility, our health and wellness in focus, serves as a powerful reminder that we cannot solely rely on governments or healthcare systems to safeguard our health. There is an inherent role for the community, corporate society, faith-based organizations, and most importantly, ourselves. We must each take ownership of our well-being, making informed choices about our lifestyle habits in an environment in which our governments enable engaging in regular physical activity, accessing the ingredients of a healthy diet, and prioritizing our mental health. As we delve into the presentations and discussions throughout this conference, let us seek solutions that not only address immediate health concerns, but also foster a culture of responsible, proactive health management. Let us champion initiatives that empower individuals to make informed choices that contribute to their long-term health and well-being and that of our families. The role of research in shaping our collective health is like the role of a teacher of young children in preschool, one of guidance and awakening of the type of thought and action that aids development. Through rigorous research, we can gain deeper insights into the root causes of diseases, identify effective treatment strategies, and develop innovative public health prevention measures. CARPHA, as the Caribbean's regional public health agency, is committed to supporting the research community in our region. We recognize that ethical research is the foundation for evidence-based policymaking and transformative healthcare interventions. I encourage all participants in this conference to engage in meaningful discussions. Together, we can harness the power of research to transform the health landscape of our region, ensuring that our communities are equipped with the knowledge, tools, and support to achieve optimal health and wellness. Thank you for your dedication to advancing our collective health. Let us embark on this journey of transformation. I commend the Ministry of Health and Wellness and the organizing team for the Jamaica National Health Research Conference for once again ensuring that research in Jamaica is showcased and exploring needed topics. May this conference be a catalyst of positive change, paving the way for a healthier and more active Caribbean region. I thank you.
Thank you very much, Dr. St. John, and for underscoring the importance of this research conference, not just to Jamaica, but to regional healthcare. And now we'll be joined online by Mr. Ian Steen, Pan American Health Organization, World Health Organization representative, Jamaica, Bermuda, and Cayman Islands. Mr. Steen?
It's difficult to follow the two presentations from Dr. Bissessor McKenzie and Dr. St. John, as they've provided a tremendous foundation on which I need to build. In this context, of course, we need to congratulate the Ministry of Health and Wellness for convening this health research conference and for bringing all the stakeholders present today. I am confident that by the conclusion of this conference, we will once again appreciate the pivotal role that research plays, not only in the development of new and effective medicines and health technologies, but in shaping health policies and administration. This year's theme, as mentioned by our host a few minutes ago, carries a tremendous important focus and emphasizes the critical role to prioritize and protect our health and overall well-being, especially with the worrying prevalence of non-communicable diseases. While this meeting will share interesting themes across public health sectors, as much research reveals, NCDs continue to overtake other threats to public health and economic development in many nations. In 2000, just as a point of reference in history, 4 of the 10 top causes of death were attributed to NCDs. However, by 2020, the research shows from the World Health Organization's global health estimates, the troubling trend upward is unnerving, and it reveals that the top 10, amongst the top 10 causes of death were NCDs had risen from 4 to 7. Approximately a decade ago, WHO members adopted a unanimous and ambitious yet seemingly attainable target of a 25% reduction in NCD mortality by 2025. 2025, around the corner. The Global Action Plan included 9 global targets and 25 key indicators. However, unfortunately, many countries have not met this target based on a number of factors, not the least of which are the substantive challenges to behavior change. These hurdles led to an extension of the Global Action Plan to 2030 and the subsequent development of a 2023-2030 implementation roadmap to expedite the response. Fast-tracking the NCD response requires immediate and strategic action. In accelerating the response, WHO urges countries to evaluate the status of the national NCD Global Action Plan implementation against the 9 voluntary NCD Global Extended Targets and the SDG target on NCDs. It also wants to identify high-impact interventions, such as the Ministry of Health and Wellness's Know Your Numbers, and address potential barriers to their implementation. We want to review and consider opportunities for acceleration and enhance national monitoring and surveillance systems for NCDs and their risk factors to ensure reliable and timely data. The call for action these days that we are witnessing amongst these conversations necessitates unwavering commitment from all the stakeholders within the health sector to achieve the 2030 Agenda for Sustainable Development. We have only a few years remaining to achieve this goal, and the Pan American Health Organization remains committed to supporting the Ministry of Health and Wellness in fast-tracking the range of interventions for the response. While reaching this milestone will require significant effort and dedication, an all-encompassing approach involving all sectors, including public and private, civil society, community organizations, schools, and religious organizations, is necessary to make this aspiration a reality. Being prepared for this task is the primary and most crucial step, and the time to take action and working towards achieving these significant milestones is now. We acknowledge all the vital roles that researchers play in guiding us towards achieving these important goals. I commend all of you for your unwavering commitment and diligence in working towards meeting the designated health sector targets and ultimately attaining universal health care. Congratulations to the Ministry of Health and Wellness, and in particular to the epidemiology team for this tremendous effort. Thank you very much.
Thank you very much for that, Mr. Steen, underscoring the importance of research in crafting effective and strategic responses in order to achieve the goals. And you know, we're good at getting to our goals, right? Right? Yes. Come on. We know our numbers. A lot of what we do at the Ministry of Health and Wellness is done in partnership with a number of organizations. We've heard from CARPA, we've heard from PAHO and WHO, and now we'll be hearing from Mrs. Adeyelu Asekun, Acting CDC Country Director for Jamaica and the Caribbean Regional Program from the U.S. Centers for Disease Control and Prevention. Let's hear it for Ms. Asekun.
Good morning, ladies and gentlemen, the Honorable Minister, Dr. Christopher Tufton, the Chief Medical Officer, Dr. Jacqueline Bissassor McKenzie, ladies and gentlemen, partners on the call, Dr. Joyce St. John, the Executive Director of the Caribbean Public Health Agency, Mr. Ian Stein, PAHO representative for Jamaica, Bermuda, and Cayman Islands, Dr. Wayne Henry, the Chairman and Director General of the Planning Institutes of Jamaica, PIOJ. Ladies and gentlemen, ladies and gentlemen of the media, allow me to stand on existing protocols. I bring you greetings from the U.S. mission in Jamaica. I am 3 months into this program here in Jamaica, and I am excited to be a part of the great work that I have observed from the Ministry of Health and Wellness here in Jamaica. The Centers for Disease Control and Prevention, through its global work, works in partnerships with ministries all over the world, as well as other partners, to enhance global health and reduce premature, non-communicable disease deaths and disabilities. In Jamaica, from HIV/AIDS to COVID-19 to research, CDC's Caribbean office has worked to implement, through a close collaborative partnership with the Ministry of Health and Wellness, to strengthen public health systems, achieve sustainable HIV epidemic control, and increase health security capacity to prevent, detect, and effectively respond to health threats. Everything stems on research. Everyone has a role to play in their health and well-being. And so looking at this year's theme of taking responsibility, our health and wellness in focus, alludes to the fact that you, me, the ministry, the community, the globe has a role to play in the health and wellness of ourselves and our families. CDC commends Jamaica's Ministry of Health and Wellness on its 14th Annual National Health Research Conference and commends the National Health Research Conference on the efforts that are being made to bring together a diverse audience, including researchers, clinicians, nurses, students, medical professionals, to learn the latest in research and to translate that into practice. Public health and medical breakthrough is the way to go, and I am glad that I am a part of this effort as a staff of the U.S. Centers for Disease Control and Prevention. As we reflect on this year's theme, the government of Jamaica and the Ministry of Health and Wellness are applauded for the push towards placing health and wellness in the forefront, not just for an institutional perspective, but from an individual viewpoint. This is a platform that we have to learn from each other, to share knowledge, to embrace technology and breakthroughs, and make a difference in the health and well-being of the community. Together we can make a difference, and we can do this by harnessing the collective power of our expertise to drive impactful change in the health and welfare of every single Jamaican. On behalf of the CDC, I wish you a successful conference, healthy deliberations, and I look forward to continuing the partnership between the Jamaican Ministry of Health and Wellness. Thank you very much, and happy deliberations.
Thank you very much, Ms. Asekun. Harnessing the collective power. I'm excited at what we can all do together. Our final greeting will come to us from the Planning Institute of Jamaica, and joining us online is Dr. Wayne Henry, CDJP, Chairman and Director General. Dr. Henry?
It is indeed a great pleasure to bring greetings to the National Health Research Conference, the NHRC, on behalf of the Planning Institute of Jamaica, the PIOJ. Health and wellness is far more encompassing than physical health. It is the holistic integration of physical, mental, and spiritual well-being, while striving for optimal health. Jamaica has in recent years been plagued with a number of public health issues, pertaining particularly to non-communicable diseases, reproductive health, and mental health. The Economic and Social Survey of Jamaica 2022 indicated that approximately 27% of the population have at least one non-communicable disease. Evidence shows that the presence of NCDs is known to impact the quality of life and has been linked to the increase in the premature mortality rate. Data from the Ministry of Health and Wellness indicates that the premature mortality rate for the four main NCDs, cardiovascular disease, diabetes, chronic respiratory disease, and cancer, in 2021 was 21.1. We commend the Ministry of Health and Wellness on its ongoing efforts to combat the issue of NCDs, and we thank our international development partners for providing financial and technical resources in this regard. We use this opportunity to highlight the support given by the Inter-American Development Bank, the IDB, and the European Union, the EU, to assist in the implementation of the Health System Strengthening Program, HSSP, for the prevention and care management of NCDs. The objectives of the HSSP are to, 1, improve the health of Jamaica's population by strengthening comprehensive policies for the prevention of NCD risk factors, and 2, implement a chronic care model with improved access to strengthened and integrated primary and hospital services networks that provide more efficient and higher quality care. The program will facilitate the upgrading of 3 hospitals and 10 health centers, leading to an enhanced experience for users of the public health system. The sexual and reproductive health of the nation's people is important and requires a holistic approach to ensure equity for all. The PIOJ is pleased to be a part of the Sexual and Reproductive Health Policy Steering Committee, which is tasked with overseeing the activities related to the development of a national sexual and reproductive health policy. This policy, which is aligned with Vision 2030, the National Development Plan, will demonstrate the Government of Jamaica's commitment to improving sexual and reproductive health outcomes and serve as a framework for the provision and delivery of sexual and reproductive health services. Approximately 2% of the population reported having mental disorders. These include depression, anxiety, dementia, as well as other types of mental disorders. The government has taken steps to address the issue of mental wellness. These include increasing the awareness of mental health and improving the accessibility of mental health services for all. Notwithstanding this, in an effort to enjoy complete health and wellness, individuals are expected to take responsibility for their own health. In keeping with this year's theme, Taking Responsibility, our health and wellness in focus, a concerted effort has to be made by Jamaicans to make better lifestyle choices. We need to eat a balanced diet, avoid food with high levels of sugar and sodium, be physically active, get sufficient rest, increase our water intake, and schedule regular health checkups with a physician. While we recognize the role of the government and medical practitioners in supporting the health and well-being of the population, a multifaceted approach is required. This approach must involve all stakeholders in order to achieve outcome 1 of Vision 2030 Jamaica National Development Plan, a healthy and stable population. It is my hope that each of us will be encouraged to make health and wellness a priority as we continue to strive to make Jamaica the place of choice to live, work, raise families, and do business.
Thank you very much, Dr. Henry. Did you know that singing is an aerobic activity? It's true. I see a lot of the doctors in the room looking at me like, what is she saying? It is an aerobic activity. It improves overall health, particularly lung function. Yes. You see? So we have to find different ways to get people. It depends on who is singing. It might do that, Doc. But listening to great music is also a total brain workout. So we're going to be working that out right now, because up next is a singer, songwriter, vocal coach, music minister, motivator. He sings to uplift his fellow man and impact the world moment by moment. And he believes that quality music nourishes the soul. Ladies and gentlemen, let's hear it for Mr. Kareem Chang.
Thank you so much. That was a lovely introduction. Were those my words? Distinguished guests, ladies and gentlemen, thank you for having me. My name is Kareem Chang, and I'm here to provide you with a little bit of entertainment. So without further ado, here we go.
Did not suffer and die to give me an education to slight, oppress, or discourage my people. Because whatsoever education I acquired out of their sacrifice of over 300 years... Look into my eyes, what do you see? Am I the same as you, or do you see something scary? What do you want from me? What more can I do for you to accept that I'm a human just like you? Crying, the crying, and the crying in the silence. Crying, and the crying in the silence. The crying and the crying in the silence. Crying and the crying in the silence. That we're just people. Don't think we're evil. We all want the same thing, peace and liberty. Sons and mothers, daughters, fathers, brothers. There's no race or color. Don't judge us by our hue. We're just people just like you. Oh, we're just people just like you. Oh, can you hear the cry of the single mother? The boy who grew up without the love of a father. Can you hear the cries of the oppressed people? Denied their rights and left to cry in silence. We're all people. We all want the same thing, peace and liberty. Oh, sons and mothers, daughters, fathers, brothers. There's no race or color. Don't judge us by our hue. We're just people just like you. Oh, we're just people just like you. Yes, we're just people just like you. We're just people just like you. Thank you, thank you, thank you. And now we lighten the mood a little bit with this one. Play it, Mr. DJ, by Mr. Jimmy Cliff. Go through. You can rock with me for this one. I can see clearly now the rain is gone. I can see all obstacles in my way. Gone are the dark clouds that had me blind.
It's gonna be a bright, bright, sunshiny day. It's gonna be a bright, bright, sunshiny day. Oh, yes, I can make it now. The pain is gone. All of the bad feelings have disappeared. Oh, yeah. Here is the rainbow I've been praying for. There's gonna be a bright, bright, sunshiny day. Look all around, there's nothing but blue skies. Look straight ahead, there's nothing but blue skies. Oh, yes, I can make it now. The rain is gone. Oh, yeah. I can see all obstacles in my way. Here is that rainbow I've been praying for. And it's gonna be a bright, bright, sunshiny day. Oh, yes, it's gonna be a bright, bright, sunshiny day. It's gonna be a bright, sunshiny day. It's gonna be a bright, sunshiny day. Yeah, it's gonna be a bright, sunshiny day. Thank you.
You didn't believe me until you heard him take that note, sky, right? Did you hear how long that was? You tried, and you find out that's great lung function right there. One more time for Kareem. Nothing but blue skies, and when you're healthy, you get an opportunity to enjoy it even more, and that's why we're here. Well, if anybody knows about, putting words into action, it's our feature speaker, the Minister of Health and Wellness. I call him Mr. Moves. Now I have to go call him Mr. Numbers. Dr. the Honorable Christopher Tufton. Ladies and gentlemen, please put your hands together for our Minister of Health and Wellness.
Thank you very much, Madam Chairperson. Let me begin by just saying that the acoustics in this room is horrible. I don't know if it's this DJ, the sound, the infrastructure, or just the room. But I think from a research perspective, we must lodge a formal complaint. How is that? You agree with that? Yeah, man, because people need to hear clearly and see clearly. It's in the interest of wellness, right? I couldn't hear half of what the people were saying earlier, especially those who are online, who we would have loved to have had in the room if they are here in Jamaica. But we thank them for their contribution nevertheless. Let me recognize all who are in the room and all who are online, and join in those who have expressed their appreciation to the Ministry of Health and Wellness, and in particular, Dr. Webster Carr and her unit, Epidemiology Branch of the Ministry, on its 14th, it's not 14th annual, it's the 14th staging, because I believe COVID was a great disruptor. You had it even during COVID? Oh, nice. Research has no barriers, right? You don't stop at all. Okay, good to see you, Dr. Mackenzie of the Oral Health team with the Know Your Numbers shirt, just like mine. Can I talk to you after? So let me just say that particularly recognize Dr. Joy St. John, who spoke earlier, who is online, Mr. Ian Stein of PAHO, Mrs. Asinkun, Acting CDC Country Director, who is on her way to Linstead, and I will be following close behind her because we have 11 o'clock there, and it's now what, well, we will be late, but she's gone ahead, but I recognize her and thank her for her contribution. My very good friend, Dr. Wayne Henry of PIOJ, and of course the team led by our CMO, and of course Dr. Webster Carr and others who are in the room. For those who are here to participate in the next few days on this critical research agenda, research conference, I want to commend you on the work that you have done and encourage you to continue in terms of the work that needs to be done going forward. I think it's impatient of debate that public health globally and certainly in Jamaica is at a crossroads coming on the heels of the COVID pandemic, and the need to rethink and to reset and to recalibrate the approach to healthcare is impatient of debate, as I said earlier. It is happening everywhere in the world, and there are so many aspects to it that time wouldn't allow me to give justice in terms of a kind of except for an overarching vision and maybe citing one or two cases. But that's why you're here, and I believe that you appreciate perhaps more than most that it is fundamental now to gather the data, to assess the data, to use the data to make informed decisions, and hopefully those decisions are done in a manner where the application of the decisions can be a reality and thereby improve the experience of those we serve and those who are actually offering the service. That's a kind of capsule version of why we do research, and in the context of public health, that's why we're here. What is interesting about Jamaica at this point in time is that in our history post-independence, I am of the view, and I know it may sound self-serving, but I'll leave you to be the judge of that, that Jamaica is experiencing perhaps the greatest transformation in public health from a number of perspectives than we have seen since 1962. And I could even go back, but let's start there, since that is a watermark in our historical evolution. We have, I believe, managed to survive COVID in a way that is not typical when the measuring of the success or critical success factors of COVID are taken into consideration, or the variables that go in. We're one of the lowest countries in terms of vaccination rates. And I've heard a kind of misdiagnosis of our success, or depending on the perspective, the lack thereof, in the response to COVID being linked to low vaccination rates. And I think that's a misdiagnosis, to use a clinical term, because on the other variables of death per capita when compared to the rest of the world, information, reach, support at the community level to overcome fears and uncertainty. On all those variables, I think Jamaica can compare with the best there is and better than most. And again, I say it may be self-serving, but I leave you to be the judge of that. For those of us who are alive and well, I think we can celebrate the efforts, not just of public health, but of the country and the government. But public health had to lead that charge. And what we had to do was to dig deep and depend on the traditional institutions of public health to reach a population that is understandably so, was very frightened at the time, as all the world was. And primary health care, to my mind, was key to that. And the functionaries at the very localized level who had to risk life and limb to go out and to make the case for the response. But out of that experience, I believe, we have a lot of lessons to learn, and hopefully we have. And to my mind, it needs to drive a research agenda around the resilience building that, God forbid, we should experience anything even close to another COVID, we would be more stronger to confront and to deal with it. What is good, and coming back now to my transformation that I'm celebrating, is that we have all the variables to make it work. This is the first time since independence we have allocated so much resources to right-sizing health against the health profile of the population, the response against the profile of the population. The first time since independence that we are engaging so many health professionals in the system, doctors, nurses, other forms of support, because the human element was woefully inadequate when compared to the demands on the system. And again, I say, I don't know of any other time in the history of public health when you could take out a 14-page, full-page list of doctors, 720-odd when the final count was made, but I think it's a little more than that, that are now going to be hired to complement the staff that currently exists. I don't know of any other time when we would have created permanent posts to address the insecurities around security of tenure, as we have with the 1,500 or so additional posts that were created for nurses and for others. I don't know of any other time since independence when nearly $300 million is being allocated to right-size the hard infrastructure, the concrete and mortar, building out major hospitals, or any other time as over the last 3 years when over $3 billion has been spent to upgrade primary health care centers to get them more appropriately positioned and restore credibility at the community-based level. Or any other time when we're spending nearly $15 million on digitizing health records, which is now a work in progress, where come next month, early December, we will go live from Maypen Hospital, which will be the first hospital outside of the University Hospital of the West Indies that will go fully digital. And I wait with excitement for that experience. So I think there's a commitment to making it work. But having said that, the extent to which we benefit from this commitment is a function of how we pull the variables together and make the variables work in a coordinated fashion. And that's where I think the research agenda has to position itself. So let me give you one example, because I don't have a lot of time, as to where I think we could face obstacles, even with the resources that we are now committing, allocating, and even rolling out in some instances. The issue around getting a mindset change in how health care should be positioned, both from the practitioner standpoint, but also from the patient standpoint. It is my considered view, subject to contradiction if others have alternative views, that the biggest threat we'll face in the health space as we move through these additional expenditures around upgrading and renewal is the change management function that is required for us, right in this room maybe outside, to see health and public health and the people's health, or to see our role as practitioners in public health in a way that is willing to deviate from the normal way of doing things. And there are many examples that I could cite. I mean, I could talk to you about advanced nurses practitioners. We were going to cabinet soon to give them limited prescriptive rights. A lot of people who don't agree with it, a lot of doctors who feel like it should never happen. It happens in other countries. It requires a kind of mindset adjustment. Nothing is wrong with having concerns and hedging and managing those concerns. But it can't be no, it can't happen, because it never used to happen. I could talk about the role of pharmacies in administering more health-related, becoming a more critical part of the ecosystem of responding to health concerns, whether it is administering vaccines or something else. It happens in some jurisdictions. In some countries where it happens, they do have a primary health care system, I understand that. But if you have 350 pharmacies around Jamaica and half of them are able to offer things that only health centers offer, then the health centers are going to have less stress on them, because at least people have those options. And the question is, how do we get our pharmacists integrated into that overarching concern of being more responsive to a population that has far more challenges, and get them to get the people and those who work with them to change that mindset. I could talk about the digitization process, which will fail if people decide not to use it. And I must say, if I'm to speak frankly, that has been one of the challenges at the University Hospital of the West Indies, because you put in this very advanced system, and the doctors didn't decide that they are preferring to put their film, the X-ray film, up against the light to look on whether or not there's an injury or not, rather than use their phone, which can move the thing from their bedroom to the operating theater to the doctor for second opinion, and voila, transaction time and cost is reduced. That's what it's all about. So we are now linking 100 health centers and hospitals digitally with networks, with tablets, with central storage of data. We have to use it, and the mindset that has to be adjusted is going to be key to doing that. I only gave you 3 examples. There are others that I think are necessary. So that change management function and how we get people to respond to a different paradigm is an area of research that I think is needed. The role of the human component in administering public health and the traditional responsibilities of doctors and nurses and the kind of silo perceptions that only, it's interesting, during COVID, the doctors would stand at the side at the arena, and the nurses would never allow them, chief nurse, the opportunity to administer the COVID vaccine. Because the nurse have fair job that, even though the doctor is well capable of doing it. And even though we're rushing to get the thing through, to get as many people as possible. So chief nurse, you're going to have to tell me, how do we get nurses, RNs, to recognize that with some training, what's the name of the category below RNs again? Enrolled nurse assistant, who I had their function last week in Montego Bay, and they were all dressed up looking good and said, Minister, we're ready to do some more work. And the truth is, we need them to do some more work, because the RNs are all flying off to greener pastures, or certainly a group of them. So the categories of work and labor are going to be critical to that. So I am only suggesting that some of the work that we do around things like NCDs and so on are very important. But what I fear is that the research agenda is not confined to traditional areas of research. A lot of times creating knowledge that is confirmatory or validating, but not breaking new ground around a new paradigm of public health. I think, when you do a PhD, they say you have to break new ground. You have to add to the body of knowledge, right? I want to see us adding to the body of knowledge in a way that says, why not? Rather than we should stick to the way. Why not? Because I think we have an opportunity to do that. The other important role, and then I'm finished, Madam Chair, is the role of advocacy. I keep saying that public health needs to see itself as advocates for the cause. It is not enough to have the research that is solid, science-based, because I know that it is the case, if at the end of it, it's only for the gratification of research-minded people. The application of that research is important. And in a sense, you have to be brave and bold and in your face and be prepared to offend, if necessary, those who feel that it no longer is in their interest for this new breaking research to take place. I like controversy if controversy stimulates conversation. And if at the end of controversy, we come to an agreement. So the debate around things like ultra-processed foods is going to bring you into direct conflict with the food industry. And there is a history around that and how it has evolved out of wars and the need for preserving foods and so on. But Jamaica is a tropical country. We have an in-season menu of foods every day. Sweet potato is always going to be better than processed rice. And anything in the tin is full of sodium and preservatives and is likely over time with other abuse of nutrition to cause some of the fastest rate of growth of disease that we're seeing, like cancers. Are we bold enough to say that and to back it up with some of the research? I am, and I'm looking for a few good men and women to provide me with the data to say it. And yeah, we might get licked down in the process, but guess what? It doesn't normally end well for those who want to be heroes, right? But you might have made a mark anyway. You agree with that? Are you prepared to get stoned for your cause? Not really, right? Stoned in the public square. So I really think that we have to take on the advocacy role a little more aggressively. So in the ministry, we are doing some of that. The epidemiologist, Dr. Webster Carr, and I have been talking about a series of lectures around evidence-based work to try and advocate for certain things. We have one coming up on ultra-processed foods that we're going to be syndicating to the other campuses and hopefully in the wider society. And that complements some of the things we're doing around front-of-package labeling, around the elimination of trans fats in the population or in the food group, and things like those that are necessary, but it involves some levels of contention. Nothing is wrong with being contentious if you are convicted that what you're doing is the right thing and it is in the public health's interest. At some point, the balance will be found because you will have alternative views and you mustn't scare away from the views. And in that advocacy, remember, people spend big money to market and to position their position. We have to do the same because a lot of it is thing. And the final point, I only say final 2 times, this is second final, is that I have advocated with the team at the level of WHO and PAHO for greater integration of human behavior into clinical science. Because I maintain that a lot of the challenges we face won't be solved on the prescription pad. It has to be solved by changing people's behavior. And I am encouraging us to spend time collaborating around research that brings the social sciences or the behavioral sciences into the clinical space so that we combine both. Because until we get people to change their action, until we can nudge people into health-seeking behavior, it is going to be an increasing level of the need for inventing more medicines and chemicals to cauterize and stabilize and give you a little more life, but with a whole heap of tablets and a whole heap of pain. And I think we have to see that human behavior component. So we need to challenge the behavioral sciences to come on board. I believe the last conference I said, who in the room is a behavioral scientist as opposed to a clinical scientist? I don't think we have 2 behavioral scientists in this room, do we? Let me put up my hand. Oh, you have 1, 2, all right, 3. So 3 out of 100, all right. Give them a round of applause. And I would like to see research proposals that are jointly done with a social scientist and a clinical scientist, so you address both sides of the spectrum. Because at this point in time, with the NCD epidemic that we have, the behavioral component is far more important, because the science has been great on the clinical side. Every day we invent something new to control. But if you look at the bill at the NHF, last 3 years of contract, next 3 years of contract, it's $27 billion. And it has gone up from, I think, 22 over a 3-year period. It's unsustainable. Unsustainable. Until we cauterize through primary healthcare reform and behavioral changes, it's going to be a difficult one. So, I sound like the prophet of doom, right? I never come here to not encourage you. I just came here to stimulate your brain and to generate some controversy. But I encourage you and I wish you all the best. And if your research meets any of what I have just said, please make an appointment at my office and let us have a sit down. Let me help you to champion that cause. Okay, Dr. Websakar? Thank you very much. Have a good time.
Thank you very much, Dr. Tufton. I like it. Did you hear the challenge that was put out to us? Yes, research, but research that's out of the box. Research that is going to open new avenues and new opportunities as researchers. And listen, as a communication for social and behavior change master's graduate, I'm very happy with all the minister had to say. Minister, did you know Miss Lou was one of the big behavioral change? Yes, Miss Lou's views, one of those people that used to champion a lot of things, including health. Yes, she had an episode where she said the ministry said, you drink more fresh milk. And Tata wants them say, but after condensed milk, not stale. What she mean? But she went around the island doing her formative research. Yes, Minister has another engagement, so please, a round of applause for him as he goes. She went around the island as a social worker doing her formative research, as you have done, and gathering people's knowledge and perceptions and their attitudes and their behaviors and putting it together in a way that was appealing to them and making the change. So we look forward to that kind of partnership. Music, again, is so good for you, right? And so, before we wrap up this morning's session, I invite the RSI Steel. I was telling you a little bit about them earlier. All-Woman Steel Pan Movement. They're known as Jamaica's finest steel pan trio. Stealing hearts and bringing beer vibes. You like that tag? Stealing hearts and bringing beer vibes. Their mission is to highlight the versatility, beauty, and unique nature of the steel pan by providing premium quality entertainment. Let's hear it one more time for RSI Steel. Thank you very much, ladies. Let's hear one more time for them. And that is how we wrap up this morning's opening ceremony. Be sure to view the poster presentations, by the way. They're in the poster hall. And leave your questions or your comments for the authors so that they know how you feel. Watch your points go up on the leaderboard. The more you immerse yourself on the conference website, the greater your chances of winning a prize. And if you post your questions in the chat room, we'll be sure to pass them on so you can engage with everyone via the live chat. So we don't want you to just be there watching what's happening. Please actively participate. Stay logged on. Very important, claim your continuing education credits. You know how important those are. And don't forget to leave your feedback about the conference by rating the sessions and completing the conference evaluation form. I want to thank Mr. Keith Foga for doing the invocation for us. Thank you so much, Takis, for setting the tone for today. Doc, Bisesa Mackenzie, I know you have 48 hours in a single day, and we are grateful that you are here with us to officially welcome us. Dr. St. John, Mr. Steen, Ms. Asay Kun, Dr. Wayne Henry for your greetings, Kareem and RSI for the great music, and of course, Dr. Tufton for that great address. I'm looking, and I'll tell you about research. I'm looking at the back and I say, I see apples, the latest research to make sure you have some guava. You saw that research? That is a guava have more fibers than apples? Yes, your research is important. Yes, I interviewed somebody and they told me, son, everywhere I go, I say, where the guava, where the guava? So what we do is important, everyone. Take responsibility. Our health and wellness in focus is what we're going to be doing for the next 3 days, and I look forward to it. I'm Delia Harris. Thank you so much. God bless.
Welcome to the Ministry of Health and Wellness Spotlight. In this spotlight, Professor Marvin Reed will provide an overview and update on the development of a national research agenda for Jamaica. Professor Marvin Reed is a Deputy Dean of Research at the Faculty of Medical Sciences, UWI-MONA. His research interests span the gamut of community medicine, clinical trials, and human metabolism. He is a former head of the Sickle Cell and Tropical Metabolism Research Units of CARE. He now serves as the chairman of the Essential National Health Research Committee and has spearheaded efforts for research projects under the COVID-19 National Research Agenda. Let us welcome Professor Reed.
Good morning, everyone. Morning to my online colleagues. Thanks for joining us today, 14th staging, our 14th National Health Research Conference. Today I'm going to be presenting on the findings or initiatives that we started several years ago in defining research priorities. And I'm just going to be explaining the methodology that we employed and give you or share with you some of the results that came from this exercise. So, by way of background, we will go through a bit of introduction where I'll set the context for the development of a national health research agenda. I will explain the steps that we took to develop the National Health Research Agenda, which will take us through 2023 through to 2028, and briefly discuss some of the plans that we have moving forward. Next slide, please. So, research is an important component of any healthcare system, and it plays a critical part in the creation of knowledge to be utilized by various sectors within the health delivery system. The term research for health reflects the fact that improving health outcomes requires the involvement of many sectors, disciplines, and stakeholders. Those of you who were here earlier and heard the minister spoke about the fact that he wanted to foster more multidisciplinary research between the social scientists and the clinical scientists. So it's not surprising that many organizations have posited and have put forward calls for health system strengthening through the implementation of research activities. And I have a quote here from CORED, which basically says that all countries, no matter how poor, should invest in developing long-term sustainable research capacity development. Within this context, countries should identify and prioritize their own research requirements to improve the health of their citizens, and secondly, should link up with global efforts to address specific conditions. The Pan American Health Organization has made a call and has developed policies related to the strengthening of health system. In 2009, they proposed that we needed to promote and generate relevant ethical and quality research to strengthen research governance and to create and define specific research agendas befitting of our region and of our country. And essentially to strengthen the whole ecosystem that revolves around research by developing best practices and enhancing the standards of research. And as such, the Jamaica decided and embarked upon a series of activities to address and to follow through or to be compliant with these calls. The Caribbean Health Research Health Policy was developed back in 2009, and it proposed a series of structure and activities for respective Caribbean countries. And one of those activities is the development of a national health research agenda. Within the Jamaican framework, we also had a complementary set of activities, which was the development of a national strategy entitled Vision 2030. And certainly, when we examine that strategy as it relates to the outputs related to health, one of the sector strategy was the introduction of a national research agenda and program to support inform planning and decision making. When we looked at the medium-term socioeconomic policy framework back in 2018 to 2021, again, the development of a research health strategy and a research health agenda was highlighted as a major outcome. So when we look and define what is enclosed or encompassed by what we call a health research system, we recognize that that ecosystem consists of several domains. It consists of the people, the institutions, and the activities whose primary role is to generate high-quality knowledge that can be used to promote, restore, and maintain the health status of populations. It can include mechanisms to adopt, to encourage, and the utilization of this particular knowledge. And so when we center this in terms of how we currently operate within the public sector, we see that there is a stated governance structure which involves the development of this national research agenda, and how this national research agenda can be used to inform national policy, developmental policy, and ultimately the development of the nation. So we're proceeding on the fact that the essential national health research as defined is to provide us with the evidence that will enable us to get the highest social returns on our investments. So to facilitate that, an essential national health research committee was constituted back in 2014, and its purpose was to serve as a governing body for the coordination of research for health in Jamaica. It provides leadership, expertise, direction, and guidance in this area. The composition of this committee is deliberate in terms of its breadth. It has educational institutions, members of the PAHO and the World Health Organization, statutory bodies such as STATIN, PIOJ, and many professional organization councils and representations from civil society. The major deliverables of the Essential National Health Research Committee is really to develop a health research agenda which reflects the national priorities on research for health and take into consideration relevant regional and global agreements, and really to formulate and monitor the implementation of the national policy on research for health. The first priority setting exercise was conducted back in 2016-2017. At that point in time, we embarked upon a situational analysis. We invited all members or all stakeholder groups, and essentially at that sitting, 59 health priority topics were identified. These topics underwent a series of deliberation and endorsement by various groups up until 2017. At that time, the 10 priority areas, the top 10 of the 59 priority areas that were identified is listed on this slide. The number one ranked area was universal access to health and universal health coverage and the impact that that had, the association of the social determinants of health with infant, child, and adolescent health, and so on. The last in the list the number 10 on the list was diabetes mellitus and its impact upon pregnancy. And we received endorsement from a wide range of stakeholder groups, which listed here professional organizations, educational institutions, non-governmental organizations. However, the recommendation of the best practice is that your research agenda should at least be scrutinized with the intent or with the eye for possible revision every 5 years. The quarterly meeting of the NHRC was put on hold during 2020 for the period 2020 to about 2022, 2023, primarily because of the fact that our resources were reprioritized, reconducted, reformulated towards addressing the COVID pandemic. Notwithstanding, now that we are back to meeting as a regular body and that a new chair had been appointed, the decision was taken to re-examine the research agenda that was developed back in 2016, 2017. And so what I'm here going to be doing now is really just to describe the process that we undertook in the revision of this research priorities. I'm sorry. So what we did was we first had a stakeholder consultation meeting in March of this year to obtain feedback on the existing priorities. And what we wanted to do was to identify any gaps in the 2017 health research priorities and develop priorities for the ensuing 5 years. And then we wanted to commence the scoring mechanisms for the new priority settings. At that meeting, we had 6 or 7 persons attending, representing a wide range of our stakeholders, NGOs, professional organizations, members of civil society, ministries of health, and regional health authorities. And after that meeting, the existing 59 list was actually expanded to 104. And subsequent to that meeting, after various iterative processes, we were able to standardize them on about 70 priorities for considerations. The priorities were then to be assessed, and the basis for that assessment was the short module that was developed by the Council on Health Research Fund for Development, and the priorities were actually scored in 4 main areas or 4 main domains: appropriateness, relevance, the chance of success or feasibility, and the impact of health research outcomes. Each individuals or each participant was asked to prepare and to score these. The scoring was actually the questions, the individual health priorities were loaded on an electronic database, which was REDCap, and individuals were asked to individually score them, giving them a scores of 0 to 4 based on the main 4 domains that I've listed here, which is appropriateness, relevancy, the chance of success, and the potential impact of the research outcome. So within that context, it meant that each research priority of the 70 research priority items, the minimum score that each item could receive was 0, and the maximum score that each item could receive was 32. And then using this, the 70 research priority questions were ranked, and we used the mean score for each priority item was used to determine their relative rank with each other. So here we had 75. So if you remember, we said there were roughly about 70 individuals who attended the conference in March. And in terms of the response to the questionnaires, we had 75 unique respondents who responded to the questionnaire. 46 of them provided sufficient data that we were able to come up with the results or the ranking system. In terms of the organizations that were involved, we got reasonably good representation from all our stakeholder groups. The Ministerial of Health component was the largest, about 48%. Universities and academia provided about 22%. Professional organizations provided another 8%, and NGOs and other ministries and statutory bodies made up the remaining portions. The research priority items were actually classified in around 23 different thematic areas. And the listing of these thematic areas is on the slide. Not going to go through all of them, but sufficing to say that they span the whole gamut of public health. Public health. So it involves things related to service, workforce, epidemiological kinds of studies. It involved the major areas of topics: oral health, sexual health, environmental related health, and it also involved monitoring and evaluation. So these were the thematic areas that were covered by the 70 research priority question items. I'm just going to be sharing on this slide the principal result or the principal finding. And essentially what it says that the top, and on this slide I've put the top 4, it really should have been top 5, but on this slide I've put the top 4, which looks at the epidemiology of the NCDs as being the #1 research priority item as agreed by our participants. Also related to the cost effectiveness of public health policies, including interventions to reduce the non-communicable disease burden, the factors affecting and the impact of unhealthy lifestyle. We spoke about that this morning, as well as factors associated with healthcare delivery, utilization and efficiency, and the quality of service of care provided within the public sectors. So these were the major top line items that, based on the ranking, that our stakeholders agreed on should be our research priority agenda within the next 5 years. On this slide is a QR code, so if you were to scan that QR code, it will take you to the full listing of the full ranking of the 70 research item. And if your scanner not working, you can actually use the very short URL that is at the bottom of the QR code, and it will take you to the full 70 research priority items and their respective ranking for your own perusal. So what's the way forward? Well, now that we have had some consensus looking at how it is that the various areas of items needed to be ranked, the next thing is really to have this being ratified by all the stakeholders who participated in this bit of exercise. Clearly, we're going to need approval by the executive management, and that executive management include approvals from the executive managements of the Ministry of Health, as well as endorsement and approval by Cabinet, and the process to do that has already been started. Once that process has been completed, one of the things that we want to do, and the purpose of this presentation this morning, is really to sensitize all the stakeholders, some of you who have actively participated before, some of you to whom this is a new presentation, is really what the agenda is looking like. And so one of the things that we would wish for you to do is to look at it, and certainly at this point, while your views will not necessarily change the ranking, we are certainly interested in how you see how you could utilize the information here in terms of the research priorities in your own local setting to advance the agenda. And really what we hope to do, as I said, and this exercise is part of it, is really to develop strategies to enhance adoption of these research agenda by our respective stakeholders in terms of your normal workflow and work processes. So that concludes my presentation, and I thank you. So I think I'm on time, so I may be able to take a question or two. Yes, please, go ahead. Could you just identify yourself?
Oh, I'm Dr. Crawford, National Family Planning Board.
National Family Planning Board.
Can you go back to the slide that deals with the categories?
Just tell me when to stop.
Pardon?
Just tell me when to stop. This one?
Before that.
Before this?
Okay, so you had a list of categories, one of which was chance of success for the research.
that thing, okay. So these were the domains in which we looked at them, yes.
Right, and how justifiable is the cost of running this research project? So the question I want to ask you is, why is it that cost was the only measure, or is it that cost was the only measure for the chance of success? As when I'm thinking of chance of success in research, I am thinking of alignment to the needs that the research would meet. I'm not saying that cost could not be a factor, but I was just wondering if alignment was taken into consideration for that chance of success.
All right, so alignment would have been taken on from our interpretation on the relevance category, so the relevance domain. So to what extent did this research meet a particular problem within the community? Now, once you rate it in terms of the relevancy and alignment, the issue is that in order for any research project to be successful, one of the major impediments or barrier to that is financial. And so in a sense, we wanted to say, yes, that you think that might be relevant, but do you think that there is a good chance, a good probability that we would be able to raise the funds to be able to execute or implement that? So I hear you. We could have put alignment on the chance of success, but because we've already assessed it in one of the previous domains, the focus on chance of success area here was more financial. And then just to reiterate, the metrics that we did was really based on a validated methodology that was already done for research agendas, broadly speaking. And these were the domains and how they were interrogated, a part of that mechanism. So having decided that we were going to use this methodology, we then had to be cognizant, what were the pros, what were the disadvantages of this particular methodology. And we were enough, in terms of our discussions and deliberation, confident enough that the domains were broad enough to cover all important elements. So in this case, as you say, alignment, for us alignment comes into category 2 where relevance was concerned. Yes. Microphone here, please. Are there any questions online? Sure, go ahead.
Okay, question. Did we account for bias, potential bias from the participants? Because I'm thinking that they would be more likely to assign a high priority to their specialty area or their educational background.
Sure. We accepted that. So there were a couple strategies that we did to try and minimize bias. On the first meeting, when we were examining the research priority questions, the previous one, and trying to ascertain whether or not new ones should be added, we actually did a part of that workshop, a survey of the Jamaica health scenario. So we had about 2 or 3 presentations, so that even though you may be focused on your own area, you were exposed to other areas of the health landscape. So we did that as a deliberate strategy. The second thing that we did as a deliberate strategy was, even after we sent out the questionnaires to the potential participants, there was active follow-up to ensure that we got a widest possible participation. So one of the things for me to demonstrate that organizational component of the research was to show you that we did achieve that. And that was due to an active thing from the Secretariat to individuals, because we anticipated that individuals may not be very willing to respond. So that was one way of enriching the sample. Now, the truth be told, we cannot eliminate bias completely, so we have to accept that there will be some residual bias in terms of the report. Individuals, if you're in oral, you're going to make sure you give your oral things the things. If you're in environment, you're going to give your environment things the very high scores. But what we're hoping, because we had a wide stakeholder group, that things will wash out. All right? Yes, Doc? It's all right. Let's let the Doc. It's the oral people. We don't want them to feel left out.
Well, that's what my question is about. I'm thinking about, Prof, the capacity in which you now occupy at looking at a sort of an incubator, because there are many individuals and many of us that have left academia some time ago. There's this sort of inhibition, mental inhibition about doing research. Are you looking at establishing the kinds of incubator laboratory where people can actually come in and build and renew their skills and capacities?
All right, so that's a very thing. So that really speaks to capacity building across the enterprise, and the short answer is yes. That's one of the things that as a research committee we are focused on in really building capacity across the whole research ecosystem. Andreen?
Yes, good morning. My name is Andreen Grant. I'm the Director of EPI Research and Analysis within the Ministry of Health. I was just pondering on what the Minister spoke on this morning with respect to twinning the behavioral science with the clinical science and looking at the outcome of our research agenda, what your thoughts are on that. He emphasized specifically the behavioral aspect of the research agenda. So in terms of our outcomes, what are some of your thoughts with respect to that?
Sure. So again, one of the purposes of the political directorate is to provide some amount of guidance as to what their thoughts are. The short answer is that as a committee, we are committed to not only developing capacity, but also allowing and facilitating the development of what we call our research priorities and our agendas. Now, the mechanisms that we will actually use to actually prosecute or interrogate these research priorities will vary. We do have some tools at our disposal at the committee level to try and guide that process. One of the tools, of course, is going to be the Research for Wellness Funds. And so within that toolkit, we can design the terms of reference to encourage that kind of collaborative efforts so that, we can basically achieve all the objectives of all the different stakeholders, the political director, the technical level, and of course the sites or the participants. So that's really where I think we can go.
Thank you. Yes. Okay. Thank you, Professor Reed, for your excellent presentation. I know that it's a lot of work, but you were able to put it together in a short time, so it is commendable. And the question that was just responded to, I also had that question when the minister spoke, but it's unfortunate he had to leave. Now, if we put the behavioral research side by side with the clinical research, you're going to find that we will be glad to do that because we need some of the lifestyle diseases has to do with behavioral modifications. So if that is so, and they're really interested in us doing such a research and collaborative work, I believe they have to put some money into such a research. At the end of the day, the overhead cost of healthcare will be so minimized that probably the hospitals and some physicians and many others might no longer be in business because we really will be glad as a nation, as a people, to save lives because the loss of life is really high. Thank you.
Sure. Thank you for those comments. Are we good for time, or we can finish this section
We're going
now?
to finish.
Finish now?
Yeah.
Okay. So, colleagues, thanks again for those of you who participated in the research priority exercise. As I said, the way forward is really for us to work with you as individuals and as stakeholder partners to see how we can develop strategies to enhance the adoption of these research priorities, how it is that you're going to be able to work towards allowing us as a country to achieve these priority items. So thank you so much.
Thank you, Professor Reed. So we're going to break and start our next session at 11:35 a.m. With oral health and non-communicable disease. A feature presentation, Dr. Mackenzie will do that. So 11:35.
Welcome back to our National No Sugar series brought to you by the Oral Health Unit in the Ministry of Health and Wellness. I'm Camila McDonald, personal trainer and integrative nutrition health coach, and I really hope that you've been enjoying our series so far. So in our last episode, we broke down the amount of sugar in the common foods that we eat. I know that was very surprising for many of you. And we also calculated the average amount of sugar that we should be consuming every day, right? We're not supposed to be surpassing that threshold, right? Today, we're going to spend some time on some lifestyle shifts that we can make right away to reduce our sugar cravings. These lifestyle changes aren't too drastic, but they're going to take a little bit of thought, a little bit of extra time, and a lot of intention. The best part is these changes are going to drastically reduce your sugar cravings and once and for all help you to get them under control. So the first thing that we need to be aware of is that most of our sugar cravings are rooted in the fact that our diets are deficient and lacking in real food, nutrient-dense food, all right, that can be used by the body to do all the things that it needs to do and keep us well and full of vibrant energy, especially anyone who may be on a diet. And so in an effort to lose weight, you're cutting out an essential macronutrient like carbs or fat. Our bodies need carbs and fat and protein, and it will not function optimally without them. So sure, you'll lose weight if you cut carbs, but you'll also be completely depleted of energy. Your cravings will be sky high, and even with all the willpower in the whole world, you're probably not going to be able to resist the craving onslaught that will inevitably follow your dieting plans. So the shift here is that in every single meal, you have to make sure that you're getting enough protein, good fats, and good carbs with lots of fiber. And when you combine this winning combo in a meal, you're going to feel satiated, full, and well balanced. If you're missing any of these main macros, you are going to crave sugar because your nutritional needs are not being met. So I want you to do an exercise for me. Every time you start to crave sugar, do a check-in. Take a look at the meals that you've had for the day and ask yourself, did I have a balanced meal today? Did I have a healthy portion of fiber, good fats, and good carbs? And the truth is that we all have very different nutritional needs, right, based on a multiple of factors. But we're going to break down a balanced meal for the average person, okay? So let's start with protein. On average, right, again, everybody's very, very different. Your age, activity levels, everything. At least 15 grams of protein in each meal or snack, okay? When you consume enough lean protein in each meal, it will really keep you nice and full for a long enough period before it's time to have your next meal or snack. Then there's fat, right? There are many types of fat, but there's the good fats. And if you're missing out on good fats in your meals, you are going to get hungry and crave sugar. Most people need about 10 to 15 grams of good fats in each meal. So even, for example, a tablespoon of olive oil has about 15 grams of fat. And you could mix up your favorite healthy dressing using olive oil as the base and sprinkle it on your salad. And there are very many ways that you can get healthy fats. For example, avocado. Avocado is in season now, all right? And that's about 10 grams of good fat. So this is just about learning how to combine your macros to give you a well-balanced meal. And speaking of which, we still have one macronutrient left, and that many of us are afraid of, but our bodies absolutely need to keep our cravings at bay, and that's carbs. It's the good kind of carbs that are filled with lots and lots of fiber, because if you really want to reduce your sugar cravings and feel full for longer, packing your meals with lots and lots of veggies in every single meal. We're supposed to be getting 4 to 6 servings of veggies every single day. They're loaded with vitamins, minerals, and powerful plant compounds that just will do so much goodness for your body, right? And then you won't have time to crave sugar. And then there are complex carbs from grain sources. So in a meal, for example, a good serving would be like a half cup of brown rice or quinoa. That works really well. And it's also high in protein, quinoa. So again, it's important that each meal and snack that you eat has a very nice variety of good carbs, good fats, and lean protein so that you can manage your hunger levels and have enough nutrient density to keep your sugar cravings at bay. Another very important factor to consider is the timing of your meals. It's important to keep satiated throughout the day and not skip meals. Of course, this might not be including days that you may fast, because I know some people fast, so that's not inclusive of that. So I've seen time and time again clients who eat their lunch at 12 p.m. and then they're so busy moving through their day. This is happening, that's happening, and then they don't understand why they want to eat down the house when they get...
All right, good morning again, colleagues. I'm Marvin Reed. I'm going to be the chair of this feature presentation session on oral health and non-communicable diseases. It is my task to introduce the speaker for this feature presentation, Our speaker is Dr. Irvin McKenzie, and he will be presenting on oral health and non-communicable diseases. Dr. Irvin McKenzie is a Justice of the Peace and is the Chief Dental Officer in the Ministry of Health and Wellness, the founding Dean of the College of Oral Health Sciences at the University of Technology, Jamaica, and a Fellow of several oral and dentistry boards. Dr. McKenzie was awarded the Badge of Honor for meritorious service in the field of health and education. He's an avid researcher, lecturer, and consultant. He's a member of the World Health Organization of Global Informal Expert Group and a member of the Institute of Dental Regulators. Let us welcome Dr. McKenzie to deliver on this topic, oral health and non-communicable diseases. Dr. McKenzie.
Thank you very much, Professor Marvin Reed. And thank you all for inviting me here today. I just want to say thank you for the organizers, for Dr. Karen Webster-Carr and her ingenuity and those who work with her in the epidemiological branch of the Ministry of Health and Wellness. Today, I present myself as Jamaica Chief Smile Builder. There's so much in a smile. A smile epitomizes health and wellness, and there are many dimensions to that. But let's continue in terms of my discourse. Oral health and non-communicable disease. As you look at my backdrop there with the waterfront, it reminds me of a place in time that I love and cherish so dearly. And I was growing up in Port Royal, and the wonderful pleasures of walking on the beach in those days. And if I had known that walking had so much health benefits, then probably I would have continued today, so I wouldn't have to be doing that later on in life. You know, non-communicable disease is what we are here to link with oral health. So, oral health is everybody's business. And today, for those of you who are in our virtual space and those who are here, one of the key takeaway message I want to say today is don't be deaf. And the acronym DEAF speaks to don't be distracted. There are so many things in life that distract us. You know, we have so many things to do, and we are not sometimes appreciative that our most important and most valid human resource is our health, our own health. And therefore, we must not be distracted with this. In terms of E, it is looking on your emotional intelligence. Many of us understand that very, very well. We understand the IQ and the EQ. And we know, therefore, that we need to build our emotional resilience, so to speak. So mental health is important. Arrogance is the third acronym. You know, sometimes we don't want to change the way we behave. We think that life owes us something. And of course, F is for a fixed mindset. So today, I'm very appreciative of this conference because we want to move from a fixed mindset into the growth mindset. Now, my agenda, I'll be talking about giving my disclaimer, objectives, defining what really oral health is, talk about a common risk factor approach, and the integrated management of non-communicable diseases, and what I believe the future holds. Now, for disclaimer, neither I nor my family, any immediate family, have any financial interests or would create any conflict of interest or restrict my independence of judgment with regard to the content of this presentation. In terms of objective, I'd like all the participants, both those who are here and in cyberspace, that they will be able to recognize the interconnectivity between oral health and general health and well-being. That participants will be able to identify, we talk about the common oral health problems in terms of cavities or caries, gum disease, periodontal disease, oral cancer, edentism, and such alike, and how it impacts on our health issues. And of course, talking about the burden of oral diseases, both in Jamaica and globally. Now, it was the Director General of the World Health Organization that said it so beautifully back in 2022 when he says, oral health has been overlooked for far too long in the global health agenda. Not only in the global health agenda, but here. So we are not going to be deaf, right? We're not going to be distracted. I'm very happy that oral health is here. 14 years after the last consideration on oral health, when the executive board 60 determined that oral health was important, here we're looking at oral health once more. This slide from the FDI shows very quickly the interconnectivity of the mouth. And in my presentation today, I'm reconnecting the mouth to the body. All right? Reconnecting the mouth to the body, Professor. So here, interesting. What oral health is. Now, oral health, according to the FDI, is defined as not just the health of your mouth and soft tissues and hard structures like teeth, etc., but that oral health is multifaceted, and it includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a wide range of emotion through facial expression with confidence and without pain, discomfort, and disease, and of course, in terms of your craniofacial complex. Oral health is a fundamental component of health and physical and mental well-being. It exists in terms of a long continuum, and its influence and values will stretch over the lifespan of an individual. It reflects the physiological, the social, the psychological attributes that are essential to quality of life. It's influenced by the individual's changing experience, perception, expectation, and ability to adapt to certain circumstances. Actually, that definition came out of looking at the 1948 definition of health, where the WHO moved away from just being focused on disease when it says health is not just the absence of certain symptoms and so on, but it encompasses the total physical, mental, spiritual well-being. And we can see why Minister went the direction in terms of looking on the behavioral, because health is very, very broad and all-encompassing. So in looking at the core elements of oral health, we are saying that oral health encompasses the physiological function of our mouth, soft tissues, etc., the psychological component, and we all know about that, because some of the most pleasurable things in life we do with our mouths. We speak soft words to our wives. We kiss our children. We eat. We like to socialize, and this is very important. And of course, we talk about the disease and other conditions. These are serious components. So this definition, this new definition, move oral health into the mainstream, and it strengthens the effectiveness of advocacy for better oral health and oral health equity, the word, equity, oral health equity. It is a recognition of the importance of shared social determinants and common risk factors, and it places oral health at the center of strategies in terms of how we address not just the local, but the global burden of non-communicable diseases. Now, the WHO, first, following the trend of the United Nations, back in 2011, where the United Nations had its second high-level summit looking on health. The first one being on HIV, but this second one focused a lot on NCDs. And thanks to the advocacy of the Caribbean community, which first started the Port of Spain Declaration in 2006, where the countries of the Caribbean advocate and began to put non-communicable diseases on the table and foremost in terms of that health advocacy. So this was the 2011 declaration, and chapter 19 of that political declaration as just a one-liner that oral health, renal, oral, and eye health should be incorporated into NCDs and could benefit from the strategies of NCDs, and we held on to it. Again, in 2014, the WHO looked at it and began to tie world governments in terms of indicators and strategies in terms of fulfilling the requirements of NCDs. The third high-level meeting, which took place in 2018, focused a lot at more how the various states and state actors can help to work together towards achieving all the goals under the NCDs. And if we notice, moving from 2011 to 2018, 2019, we're moving from the Millennium Development Goal into the Sustainable Development Goal, where the Millennium Development Goal had a sort of a predilection more towards infectious diseases, and the Sustainable Development Goal looking at more some of the non-communicable diseases. Looking from the health economic perspective, they saw that where non-communicable diseases in terms of health expenditure had a very slither or a reduced budgetary support. And yet still, NCDs were the major and leading cause of death and disability. 70% of the world population die as a result of NCDs. Now in 2022, the WHO produced what is called the Global Burden of Disease Study, taken from the 2019, Global Disease Burden Studies. It produced what is called the Global Oral Health Status Report. And in this report, it actually showed that approximately 3.5 billion people globally, 3.5 billion people globally suffer from the ravages of oral diseases. About 180,000 from oral cancers. And when you look on dental caries, which seems to be one of the major drivers, it is looking at nearly going to 2 billion individuals suffering from these diseases. And of course, the message is, like non-communicable diseases, most oral diseases are preventable. And if not prevented, it will cause significant cost just to care, and it can become a serious burden on the health system. The WHO report that about $545 million US dollars is expended in terms of managing oral diseases. So in terms of framing the argument today, I just want to say that when you look at all the disease that encompasses oral diseases and condition, it fits oral disease quite snugly into the definition of a chronic, non-infectious, slowly progressing disease that affect people over their life course. And this is very, very significant in terms of oral health. In terms of looking at where oral diseases rank, the global report, looking at the World Bank report and others for low and middle income countries, low and middle income countries, even the higher countries, oral diseases rank number 1 in terms of all epidemiological studies. And this is a fact. In looking from the Global Burden of Disease survey in 2019, we see here it was 3.47 billion persons suffering from oral diseases. Then look on the others where we talk about chronic non-communicable disease, like cardiovascular disease, 522 million, diabetes, 458 million, chronic respiratory diseases, 543 million, cancers, about 86 million. Put them all together is approximately 2 billion less than the oral disease prevalence. So oral diseases are indeed very, very important. It's a sort of, I would make the argument that is a sort of a epidemic, a pandemic of sort, Professor Reed. So in terms of looking and also on the impact, the deleterious impact of the 4 top oral diseases, caries, periodontal disease, edentulous, etc., there have been one of the major cause for catastrophic health expenditure. And you can ask any Jamaican about it in terms of seeking oral health care. As I said before, most oral diseases are preventable. So here is a nice picture I like to show about periodontal disease. And the oral health thing is important because it not just affects your general health, it affects your well-being. It affects the way you think about yourself. It affects your self-esteem. I'm very happy to say in the Ministry of Health, we have been able, through our Second Chance Smile program, to help to rehabilitate people's trust and confidence in themselves through our denture program. Here are some of the deleterious effects and impacts that oral diseases have on the individual. Some people, because of poor oral health, you have fear and anxiety. There's pain. There are numerous studies that document even learning is impaired among children. And we know that oral diseases are the most prevalent chronic disease in childhood. And those are facts. Of course, we can talk about the whole aspect of functional limitations. And looking closer home, look at the economic impact. Total expenditure on dental care in Jamaica in terms of the millions of US dollars is about 45 million US dollars. But the per capita expenditure is just about $16, and it's tell you how much we spend on oral health. And of course, when you look on the productivity loss from the 5 most prevalent oral diseases in US dollars in Jamaica, WHO data is saying $60 million of loss. So oral health is very important, not to mention the impact of the other non-communicable diseases. Here, our local picture shows the prevalence of untreated dental caries, deciduous teeth. Remember, caries is a chronic process. Among children 1 to 9 years old is 45%. In terms of the prevalence of untreated dental caries in permanent teeth is 30.1%. Periodontal disease prevalence in individuals 15 years and older is 22.7%, putting Jamaica in the top 15 countries with very terrible periodontal diseases. And then look on edentalism. Oral health is important for nutrition, right, Sandra? And good nutrition is very important for oral health. So there's this connection, there's interconnectivity between oral health and non-communicable diseases. If you look on lip and oral cavity cancer, we know that there are some cancers that are caused by the HPV, but most of those cancers are usually cancers in the oropharyngeal area. But the rest of the mouth cancers are usually caused from things like tobacco smoking and such the likes. When we look in Jamaica, we can see in terms of the prevalence, the incidence is low, prevalence low. But when you have a high case fatality rate, your prevalence will be low. When we look at the statistic in terms of looking at 5 years mortality rate, by the time we diagnose individuals with oral cancers, they are deceased within a year or 2 years. It's very, very important. The burden of diseases is tremendous. When you look at the risk factors, and this is where we want to begin to tie oral health with the chronic non-communicable diseases. Because oral health and the chronic non-communicable diseases share the same risk factors, just as the high level, that the United Nations high-level political declaration showed in the first instance back in 2011, that oral health could benefit from the same strategy and for being integrated with non-communicable diseases. So we see here in Jamaica, the per capita availability of sugar is 134.8 grams. And my good friend Sandra and Dawkins and other things would tell me that in total number of sugar a young lady would need, adult woman per day, added sugar, free sugar, is about 24 grams, right? Am I correct? And for an adult male, somewhere about 36 grams. But Jamaicans, in terms of consumption, is consuming on average 134.8 grams of sugar daily. We are eating ourselves to death. So I can understand Professor Hilaire Beckles when he says it's a sort of an epigenetic of sort. Because we leave the plantations when our foreparents and foreparents were slaves. But the sugar from the plantation has never left us. Neither the salt from the salt barrel. And that's why we have so much problem with what? Diabetes and hypertension, to quote Hilaire Beckles. So in looking on the common risk factor analysis, we see diet, we see tobacco, the harmful use of tobacco. As somebody would say, tobacco is the only legally available substance that when used as the manufacturers prescribe, it ensures that it kills you. But we use it just the same. Alcohol abuse. We talk about physical exercise and so on. It's important. And impaired nutrition. And you just look at my slide, you can see there's an overlap with the chronic, with the risk factors and oral diseases. Alcohol impacts oral health. Likewise, tobacco, likewise, poor nutrition, etc. So we can see, and these are the major diseases here. So any strategies that are focused on a risk factor approach that are determinant based in terms of your non-communicable diseases will, in effect, help to improve oral health. So oral health is here to stay. When you look on dental caries, this is the most prolific and most prominent oral disease. Just imagine the anatomy of your tooth. Enamel is the hardest substance in the human body. And because of sugar and a microorganism acting using that sugar as a source, substrate, can produce the plaque acid, etc., that could burn that tooth and burrow into that tooth, actually destroying. And remember, the enamel is stronger than bone. What is that saying? As I said earlier, oral health is everybody's business. When our medical doctors or nurses, as Minister mentioned, nurse practitioners, when you see your patients with diabetes, hypertension, upper respiratory or lower respiratory tract diseases, etc., with cancers, and they come there and you can look straight in the most accessible cavity. Do you have the conversation? Oral health is important to health. So we are challenging the physician, the nurse, and the pharmacist, and every healthcare provider. It's not a dental thing. So we talk about the integration. We are talking about workflow. We are talking about having that conversation with the patient. Having that conversation, that intentional conversation about their health, their most important human resource. It may start as a white spot lesion on the tooth. That indicates demineralization, etc. But that's how it begins. Now, I'll just wrap up by talking about the 6x6. The recent publication of the Lancet focused on what the WHO and other international agencies looking at. First, it was about the 4x4. 4 disease conditions with 4 risk factors: cardiovascular disease, diabetes, cancers, chronic respiratory diseases, tobacco, alcohol, unhealthy diet, etc. Now it has gone from 4 to 5 with mental health and air pollution. And it is well documented the impact of sugar and the problem sugar can cause and the relationship of sugar and oral health and diseases. And we are advocating that we all not be deaf, but it's time that we put oral health back in the agenda, because oral health is general health and well-being, and it is important to chronic non-communicable diseases. So we need to advocate, just as we did in 2006, to put the framework forward for a 6x6. Thank you very much.
All right, colleagues, we do have some time to take some questions. Are there any questions both online and in room? I have an in-room question. Can I get the mic to her, please? So a quick introduction. Sure.
Thank you very much, Dr. Mackenzie, as usual. Very eloquent presentation. Oral health always shines out there, but I'm wondering something, Dr. Mackenzie. And maybe my thought process is incorrect and I stand to be guided. I'm of the opinion, despite the many information, and I'm still not convinced, I need to change the way I think about it, that oral diseases and conditions are herald for NCDs rather than a separate NCD. And you have basically affirmed that in my head in your presentation, to be honest, because now we're seeing that the risk factors, again, it is one of the earlier manifestations that something is not right in the body. And usually, if not properly attended to, the same thing that worsens the obvious manifestation, because it's right there, is likely to eventually manifest in one of the other NCDs. Is it possible, again, that quite rightly, we need to address it because it signals that there's an underlying problem in all the factors that contribute to good health, and that the oral health is more signaling that we need to start intervention earlier rather than by itself as a separate query?
That's correct. What we do believe is that we need to, that oral, in terms of the oral health approach to NCDs, our dental surgeons and dental practitioners, we do not manage diabetes, cardiovascular disease. We manage the oral health component of those diseases. And we help from dealing with the same risk factors that impacts those chronic non-communicable diseases. And it's a fact that even though it has a standalone nature, that we have found that when you have a priority focus, where the government and the WHO and regional bodies begin to spend money on that particular area, that from a strategic perspective, you put your 2 cents in, you show the connectivity and how it interconnects, how it relates, and in that way you're also able to move that agenda forward. What it also do very quickly, it moves us dentists and us physicians and nurses, etc., from having the silo approach to health to being all-inclusive in terms of how we deal with health. Definitely.
An efficacy of our broader program for the control of NCDs and all the other major burdens.
100%. We usually see our patients much earlier than when the other NCDs begin to show. And because there are so many systemic manifestations that we can see orally, and we can see those risk factors manifesting very early. So by doing the kind of screening and early intervention, we too will be able to, as you say, help in terms of being part of that process that will signal that we can help to prevent the NCDs from happening before it does occur. Yes. Yes.
Thank you very much, Dr. Mackenzie, for your excellent presentation. I would just like to ask you directly to tell me if behavioral modifications will bring about the desired need of adjustment that will lead to control and prevention.
100%. Normally, in looking at any disease process, when you begin to evaluate the determinants of those diseases and the impact of those determinants, you'll find that usually the clinical determinant, somewhere the literature shows, is about 10 to 12% effective. When you look at the socioeconomic determinant, it's about 10 to 15%. But when you look at the behavioral determinants, it's about 45. So behavior has everything to do with it. It's not about the overconsumption of sugar or the abuse of tobacco or alcohol. It's that how can I change my behavior? How can I change those harmful activities that I am doing that will ultimately cause my demise? because that's what it is. It ultimately caused your demise because your health is your most important resource. So it takes concerted individual action, yes, to deal with that. Yes, Dr. Grant.
Yes, good afternoon. Thank you for the excellent presentation. I'm happy that you mentioned the determinants of health because that is what I was thinking about in your presentation. Yes. So in terms of coverage, affordability, and access, we know that the social determinants of health in terms of socioeconomic status, etc., that there will be a category of the population that will be particularly challenged. So I'm wondering, from your perspective, what can be done to address that in terms of improving access, affordability, etc., and is that on the table with respect to the discussions?
Yes, that is on the table. But in terms of access, I just want to look at how we are reorienting our service. Our major priorities right now is prevention. Because we have moved the NCD agenda to incorporate the universal health coverage. And the universal health coverage is talking about people accessing care, the kind of care that is needed at the quality it is required without them going into financial hardship and suffering financial hardship. So we have realized by reorienting our focus on health education, health promotion, an aggressive health promotional campaign, we are capable of reducing future diseases. But in terms of those that currently exist, we have a significant problem in terms of access because of the existing workforce is not enough, and just where you live in Jamaica is not everybody will have access to the kind of dental care that they require. And of course, we must remember the cost of dental care is prohibitive. So prevention is really the way to go.
If I could just follow on the matter of access and how can we expand the access. Is there consideration to probably including in a tool or instrument that can assist, separate and apart from referring to, assist the first point of care provider in doing at least preliminary, separate and apart from the history and examination, taking into what happens with oral health practices, but a rapid assessment that can allow for some kind of guidance for the patient who's seen or the client who's seen at the first point of care to expand the access. Is there a tool that's available?
Yeah, there's a tool. Right now I can tell you quickly, Professor Tollereed and the University of the West Indies have been working on a tool, and this may be relating to diabetes. I'm so happy that the Ministry of Health has prioritized diabetes, and oral health is linked there with diabetes because the data shows, even from NICE, National Institute of Clinical Excellence, that when you screen a patient for periodontal disease on a consistent basis or a frequent basis, and you can help to prevent periodontal disease, it helps to reduce the glycemic index by as much as 1.25%. So it is, you can imagine moving from 7 to 6 or moving from 6 to 5. So that tool is very, very important. But very important, I want to say, as I started off, oral health is everybody's business. So we like to encourage our physician to have the conversation with the patient. When you see, talk to them about their oral health, their oral hygiene. Look in the mouth. Please look in the mouth. And because it may be the first point of referral. And likewise, dental surgeons, when we are treating patients, and we see patients that are obese, patients that look like they may be predisposed to any cardiovascular disease, to have the discussion with the patient about their health, their general health and well-being, and refer them to the physician. This is looking at the IOM approach, Institute of Medicine approach, to putting back the patient in the center of the health agenda. Yes, Chief Nurse, Deputy Chief Nurse.
All right, so just quickly, I had stepped out for a minute. I don't know if you had addressed this. I heard Dr. Dawkins-Wright spoke about access, but I know that there was some scaling down of oral health services some time ago, and some of the access points in the more rural or remote areas were removed. And if we're speaking to screening, we must provide the service. And I'm thinking that we need to seriously look at how we can improve access for those persons living in those remote areas by reintroducing the service, because I know it wasn't, the service existed in some spaces before. So we need to look at reintroducing the service in some of those more remote areas, so that as we screen and we identify the issues, persons can have access to service.
Amen.
All right, but before you go, Dr. Mackenzie, I just wanted to speak to you and ask you about the role of AI and technology as part to complement the screening sets of activities. Because while you present, I was wondering if we couldn't just take a picture of somebody's open mouth, send it through to AI, and we get something going out of there.
Professor Reed, as the researcher you are, you would have gone to the future. We are now looking at various modalities to care, and this helps with the actual increase in access. As you know, telemedicine is here, and we dinosaurs need to wrap our minds around it, because COVID-19 showed us that we started with telemedicine. Our patients just didn't turn up anymore. We talked to them on the phone, asked them, where were you? Anybody in your family have any fever or cold? Are you in a community where it was locked down? And this is rudimentary telemedicine. So as Prof has rightly said, there is a role for AI, because if you want people to have access, we may not be able to put a dentist in every community, but almost every Jamaican may have a phone. And they may be able to take a picture and send, this is what I see in my mom's mouth or my granduncle's mouth. And you can easily get back to them. So I believe there is a role for AI. There's also a role for mobile dental services. And there's a role for our medical doctors who like to walk away from the dental agenda and leave it only to the dentist. And our nurses, deputy chief nurse, our nurses, deputy chief nurse. Health is our business, and oral health is part of general health and well-being. And when we begin to refer quickly, we found it with the antenatal programs by upstreaming our programs and having the discussion with our nurse midwives, that we begin to see more referral. And this is coming from zero. No antenatal patients were referred. We're moving from zero diabetic patients being referred to dentistry to now we're having more diabetic patients coming for oral health care. So educating ourselves and conferences like these help us to grow. So I'll end by saying that childhood curiosity that we had in the beginning of our lives, looking at this space and wondering what is out there, let's keep that curiosity going. Be hungry. Continue to learn. Continue to do more research. And I hope that Professor Reed come and talk to my dental group, because we want to do some good research.
And with that, we'll bring in this session to a close. We'd like to thank Dr. Mackenzie for his presentation. I gather there is a presentation to be made to the speaker. Who's going to be making? Oh, Dr. Grant. Oh.
So we want to firstly thank Dr. Mackenzie for the excellent presentation, and based on the depth of the questions, you can see that many persons were engaged in the conversation. So we just want to thank you again for an excellent presentation. Is there, okay.
There's no toothpaste in there.
I hope there's no sugar in there. Thank you very much.
You're welcome. And for Prof. Reed, so he did dual duty this morning in terms of the initial presentation on the research agenda, and then to come and ably moderate. So we just want to thank him once again. But he is a part of the family, so we just want to thank Prof.
All right, colleagues, the session is now closed, and we go for Jamaica Moves break. We'll return in what, 5 minutes? In 5 minutes, please. Thank you so much.
1, 2, 3, 2 more. 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Love your body, treat your body right. Love your body, treat your body right.
Good afternoon, everyone, and welcome to our first scientific session. Now, this afternoon, we will have 4 researchers presenting. We will take the first 2 presentations, and we will have 5 minutes allotted for questions and answers. Then we will move to the final 2 presenters, and we will have another round of questions and answers. I will start with the introduction of the first 2 speakers, and then we will move into the presentations. Our first speaker, Dr. Ian Campbell, has a PhD in biochemistry from the University of the West Indies, Mono. His primary area of expertise lies in the biochemistry of overtraining in athletics. In 2021, he started duties as a biostatistician at the National Epidemiology Branch in the Ministry of Health and Wellness, which led him to an expansion of his interest in epidemiology research, particularly in understanding the mortality profile of Jamaica. Currently, he serves as the Senior Statistical Analyst in the Research and Policy Development Branch at the Ministry, which has broadened his interest in health policy research and development. Today, we're happy to have Dr. Campbell, and he will be presenting on the potential years of life lost in Jamaica between 2010 and 2020. Following him, we will have Dr. Lorianne Fisher. She is a consultant nephrologist at the University Hospital of the West Indies and honorary lecturer in the Epidemiology Research Unit of the Caribbean Institute of Research. Dr. Fisher completed residency and fellowship in the United States, and then she returned to Jamaica. Her research interests include the epidemiology of kidney disease and its risk factors in the Caribbean, as well as sickle cell nephropathy. Dr. Fisher has published on acute kidney injury and chronic kidney disease in Jamaica. Today, she will be presenting on chronic kidney disease in Jamaica, updated national prevalence estimates, and associated factors using CKD EPI 2021 formula. Dr. Campbell will now come, and immediately following will be Dr. Fisher. Please put your hands together and welcome our presenters.
Good afternoon, everyone. I'll be presenting on potential years of life lost in Jamaica, 2010 to 2020. So the world has experienced an epidemiological transition. There has been an increase in the prevalence of chronic diseases and disabilities. The mortality associated with chronic diseases and disabilities has been widely quantified using conventional methods such as death count, crude rates, and standardized mortality for assessing the burden of diseases. For all these methods, deaths are counted and are strongly influenced by deaths occurring in the older age groups. An alternative method, an old formula with new ideas, potential years of life lost, counts the healthy life years from illnesses and disabilities. So this is a graphical representation of potential years of life lost. It shows that a younger individual would have greater years of life loss compared to an older individual. The potential years of life loss sums years of life loss before life expectancy. It is a summary measure of premature mortality, making it an essential function of public health surveillance. Currently, there is no recent assessment of potential years of life loss for Jamaica. Therefore, the aim of this study was to analyze trends in potential years of life loss from 2010 to 2020 in Jamaica, disaggregated by sex. To achieve the aim, the study used a secondary analysis of data from the Registrar General's Department. Also, we used population count or estimates from the Statistical Institute of Jamaica, or STATIN. So in terms of procedures and data acquisition, mortality from 2010 to 2020 by cause were obtained from RGD. Cause of death were coded according to ICD Code 10 to obtain a list of causes in sufficient detail to capture all conditions relevant to Jamaica. We classified deaths according to the National Burden of Disease Manual by WHO. So we classified disease into level 1, which are the large group of causes, such as the NCDs, into level 2, which is a broad group of causes, such as diseases of the circulatory system, into level 3, a more specific group of causes, such as into cerebrovascular diseases, which is a disease of the circulatory system, and a NCD. The key variable used in this study are final underlying cause of death. And this is defined as disease or injury that initiated the train of events leading directly to death. So it's a time series study, so we use years from 2010 to 2020. Also, we looked at 6 and 5 years age groups. In terms of data analysis, the statistical software Stata was used. Death count was used to establish a cause of death ranking. A standardized mortality rates were calculated. Potential years of life loss was calculated as the sum of death in each age group multiplied by years of life loss before 75, which is the global life expectancy. Relative percentage change was calculated, rates were plotted, and 3-year moving average were applied to smooth the rates. Chi-square test was used to evaluate trends, and statistical significance was always set at p less than 0.05. Now on to the results. So first, I'll give the demographic profile of Jamaica. So in 2009, the Jamaica population was 2.691 million people. By 2019, the population increased to 2.733, representing a 2% increase. This amounts to an average of 14 more people each day over the decade. And throughout the decade, there were always more female than male in Jamaica. So this is the population, age, and sex structure of Jamaica in 2009 and 2019. In 2009, the largest proportion of the population was aged 15 to 19. By 2019, the largest proportion of the population was aged 20 to 24. So this shows that Jamaica experienced an aging population. The number of live births and birth rate declined in Jamaica over the last decade. Though birth and fertility declined, general mortality increased by 6%. And general mortality rate was usually greater in males than in females. So now I showed you that general mortality rate increased. So now what's killing people in our population? On your left, which is the top 6 leading causes of death in terms of count, it shows that cerebrovascular disease or stroke was the leading cause of death in 2010 rather. By 2020, diabetes was the leading cause of death in terms of count. On your right are the top 6 leading causes of death in terms of potential years of life lost per 100,000 population. So assault is the leading cause of premature death in our population. The trend analysis from 2010 to 2020 for the leading cause of death in terms of potential years of life loss are presented here. And it showed that the assault, which is violence or physical attack on subtracted twice as many potential years compared to other conditions causing premature deaths. So here I pull out the other conditions. These are the unsmooth rate. For presentation purpose, we smooth the rate. So these are the smooth rates. So potential years of life loss significantly increase across the decade for all conditions except HIV, which has a significant downward trend. So these increases in potential years of life loss indicate individuals died younger from these conditions as the decade progressed. Sex breakdown for the average for the decade. It shows that HIV was the leading cause of premature death in female, and assault was the leading cause of premature death in male. So the leading cause of premature death in male, which is assault, subtracted more than 5 times the leading cause of premature death in female. So examining trend for the leading cause of death in female shows significant decrease across the decade for transport accident and HIV. However, potential years of life loss significantly increased for the NCDs, such that younger females dying from diabetes, hypertensive disease, and ischemic heart disease increased by more than 50% across the decade. On the other hand, examining premature death for males, note the wide gap between assault and the other condition causing death. So assault was 3 times greater than any other leading condition causing premature deaths in male. So examining trend in the other leading causes of premature death, only HIV showed a significant negative trend in premature death. Potential years of life lost significantly increase for transport accidents and NCDs, such that the rate of younger men dying from diabetes, stroke, hypertensive disease, and ischemic heart disease increased by more than 50% across the decade. So this being younger people are dying from NCDs and also transport accidents. So in summarizing the key finding, this analysis shows an increase in Jamaica's disease burden and an equal increase in the number of Jamaicans who die too young. Potential years of life loss in Jamaica differed by sex, where external causes were the leading cause of premature death in male, and HIV and diabetes was the leading cause of premature death in female. The other leading cause of premature death were NCDs, was significantly increased across the decade, indicating Jamaicans are dying too young from NCDs. So data from Jamaica Healthy Lifestyle Survey showed an increasing trend in NCD, suggesting that potential years of life loss may continue to increase. Some important implications for the study, potential years of life loss data highlight the relative importance of those causes of death that currently subtract several healthy life years from individuals. And knowing the magnitude of disease burden in our population may help with planning and public health decision making. So for a future study, follow-up analysis of premature mortality by geographic area in Jamaica is warranted, as it could provide insight into the allocation of critical social and public health resources. So this study has important limitations that we should underscore. One important limitation is diagnosis listed on death certificate are sometimes miscoded. So in conclusion, this analysis highlights the burden of premature death in Jamaica and suggests that individuals are dying before their life expectancy. The majority of premature deaths were preventable, suggesting a need for targeted public health intervention. These are the references used for this presentation. Thank you for listening.
Hello. My slides are not up yet. Okay. I'd like to take this time to thank the organizers of the Ministry of Health and Wellness Research Day for allowing me to present our work on chronic kidney disease in Jamaica, updated national prevalence estimates, and associated factors using the CKD-EPI 2021 formula. Chronic disease is a major public health problem and is defined as alterations in either kidney structure or function lasting more than 3 months. This is manifested as either an estimated glomerular filtration rate, or GFR, less than 60 mils per minute per body surface area, or markers of kidney damage. And of the markers of kidney damage specifically used in the definition is albuminuria, which is an increased urine albumin excretion, so an albumin-creatinine ratio of greater than 30 milligrams per gram or 3 milligrams per mole. It can also be manifested as abnormal urinary sediments, renal tubular disorders, histological abnormalities on renal biopsy, or structural abnormalities on imaging. But the working definition, for the most part, is albuminuria or reduced GFR. As we know, CKD is associated with increased public health burden, and it's a leading cause of mortality, cardiovascular, and cognitive impairment. The image that you showed, which is off now, was showing the CKD heat map. So the purposes of the heat map is that as GFR declines and albuminuria worsens, meaning the bigger the drop in your GFR, the worsening. I'm sorry, I'm just going back to that slide that we missed out. Sorry. Yeah. So essentially, this heat map shows mortality, and mortality increases with dropping in GFR and increasing albuminuria. So what's highlighted in the red are those people with the highest risk of death, so cardiovascular death and progression to kidney failure. A prevalence of CKD in the world is estimated at about 9%. And again, reminding the definition, either a reduction in GFR or allomenuria. Latin America has amongst the highest burden of CKD, even adjusted for level of socio-demographic index, and there is paucity of data in Jamaica on epidemiology. Barton and colleagues estimated prevalence of CKD as 327 per million population, but the definition of CKD was just a creatinine greater than 150, which would exclude most people with current CKD definitions. Diabetes is the leading cause of CKD worldwide. Based on data from the Caribbean Renal Registry, hypertension was leading cause of CKD in Jamaica. Given the lack or paucity of data of CKD epidemiology in Jamaica, we opted to estimate the prevalence of low estimated GFR amongst Jamaican adults, so a GFR less than 60, using the newer race-free equations. So this newer CKD epi equations, which I'll get into a little bit later, removes the race component because it is now recognized that race is a social construct. To identify the demographic, socioeconomic, and clinical factors associated with low GFR in Jamaica. We used a community-based interviewer-administered survey of non-institutionalized Jamaicans residents in Jamaica. It was cross-sectional in design, and we used a multi-stage sampling method, or the quiche method, which is similar in the Jamaica Health and Lifestyle Survey 3. We measured demography, self-reported medical and medication history, education level, employment status, physical activity were obtained by the questionnaire. And again, this is from Jamaica Health and Lifestyle Survey version 3. Blood pressure and arithmetric measurements were measured. Waist circumferences were obtained by trained personnel. The sample for creatinine was analyzed using a Cobias or a Roche analyzer. Our outcome variable was low estimated GFR, which I put in quote CKD, and that was defined as a GFR less than 60 using the newer equations that are now recommended to estimate GFR. And for patients who are persons who are 60, who are 20 and over, and the Swartz line equation, which is recommended for adolescents between 15 and 20 years. Our exposure variables included hypertension, which was defined as measured BP greater than or equal to 140/90, or if on the questionnaire they mentioned that they were on medication for hypertension. And the definition for diabetes, as reported there, and obesity greater than or equal to 30 kilograms per meter squared, and sickle cell was self-reported. We used a subpopulation from Jamaica Health and Lifestyle Survey, which included a final sample size of 1,089 persons. These are people who had data on creatinine and survey weights. Estimates were weighted by survey design. We assessed differences between low GFR and high GFR, or our outcome variable based on age, sex, presence of diabetes, hypertension, obesity, sickle cell trait, household possession, terciles, and highest education level. Parsons chi-square tests were used for proportion, and t-tests and ANOVA for differences in means. A p-value less than 0.005 was considered statistically significant. We used logistic regression to measure effect factors on developmental or outcome of interest. In the final multivariable model we created using variables with either an a priori association with CKD, or if on univariable analysis, the p-values were greater than were less than 0.02. I apologize. Missing data was handled by complete case analysis in multivariable models. In terms of our final results, the mean age of the population was 49 years. There were 433 females and 446 males. The prevalence of CKD overall was 7.6, confidence interval 6.1 to 9.6. 7.3% of males had CKD, 8% of females, and this was not statistically significant. And there was no difference in proportion of CKD between males and females, I should say. Most of the participants had CKD stage 3, which is a function between 30 and 59, and that was 7%. 0.2% had a function between 15 and 29%, and 0.4% had a function between 15%, lower than 15%, which usually indicates kidney failure. So in terms of demographic differences between persons with low GFR and normal GFR, people with low GFR were older, 65 versus 47 years old. Clearly would have lower GFRs and higher creatinines, right? So low GFR's mean was 50 plus or minus 11, and normal was 89. They had higher systolic blood pressures, so people with low GFR had higher systolic blood pressures, 142 versus 130, and a higher cholesterol, 4.7 versus 4.5. In terms compared to those with normal GFR, persons with a higher proportion had hypertension, a higher proportion had diabetes, and a higher proportion had self-reported sickle cell trait. In addition, a higher proportion were less than high school educated. In the final multivariable model, age was associated with a 7% increased risk of CKD. People with diabetes and sickle cell trait were 2 times more likely and 5 times more likely, respectively, on the multivariable model to be associated with CKD. The prevalence of CKD in our population was 7.6%, which is 1 in 13 Jamaicans. Please note that this is low GFR, not total CKD. There was a high rate of advanced disease, so I mentioned it was 0.4%. That's 40 in 10,000 persons versus 7 in 10,000 persons worldwide. So advanced kidney disease means a GFR under 15, which means that they will need dialysis or renal replacement soon. Hypertension didn't increase risk on multivariable models. It wasn't statistically significant, but diabetes and sickle cell trait was associated with a 5-fold increased risk. It may imply the role of a genetic and or environmental risk factor, which is potentiating this risk. We are trying to analyze and are currently analyzing now the Almanor data so we can get a complete rate of kidney disease. And I would like to take this opportunity to thank all the collaborators at JLS. I'm sorry this took a little while. Sorry. Can I go back to the last slide, if you don't mind? Okay. And Professor Trevor, so sorry about that. This is writing and particularly my mentor in this project, Professor Trevor Ferguson and Marshall Tallereed, in addition to everyone listed here. Thank you.
All right, we're going to open the floor for Q&A. I'd like a mic for my presenters. And does anyone have any questions? Online, are there any questions online? There's a question? And we also want a mic for the presenters.
Thank you for your presentation. Thank you for your presentation. Okay, my question goes to Dr. Campbell. All right. While I was listening closely, the potential years of life lost in Jamaica between 2010 and 2020. Excellent work and excellent presentation. Now, you showed to us that those factors were external factors, right? All right? And there was a limitation. The limitation was cause of death was not coded correctly. Is that true? Okay. So, what would have been the case? Is it like the life expectancy is very low because of this external factor, and at the point of death, something else was indicated as the cause of death? Is that what you meant by
If that's what I meant by?
not miscoded?
No. It's human error. So it's a medical doctor who code these causes of death.
Okay.
So there are potential for human errors.
Okay. Oh, that was human error. Okay. All right. Thank you. That is one. Then the next question is, I just want you to tell me, right as I'm looking at you, what do you think will be the best bet to increase our life expectancy?
That's a tough one, but
Mike.
Okay, but to increase your life expectancy, I mean to increase to reduce dying young, or to reduce life expectancy in Jamaica. Because I presented on potential on dying young. So you want me to say?
No. Okay. Now, we want people to live longer.
Okay. I mean, there's a lot of.
So we want them to live longer. All right? But we realize they are dying prematurely.
Right.
So how do you think, as a young man, how can we make modifications? Okay. I want you to tell me. I know the answer, but I want you to tell me something.
Yes, and I'll tell you.
Thank you.
So as you saw, the top 6 leading causes of death are lifestyle diseases: assault, transport accidents, and the NCDs. Their lifestyle diseases. Yeah. So as a behavioral scientist, I am sure you would have some answer into some of the behavioral modification that we could use to increase increase dying young, or to increase life expectancy, to increase the life expectancy.
Yes. Okay.
Right.
So the young men are not invincible, no? We have to let them know, hello, young man, you need to keep your life in check.
Right, you need to keep your life. So there are, as you know, there are behavioral factors, there are common behavioral factors: nutrition, which is nutrition and dieting, exercising.
Okay. Let me ask this like this. If you as a young man, if somebody comes to you eating certain type of food that you know will jeopardize your health, and somebody tell you, say, no, ma, my young man, I'm all right, I'm strong. You've gotten that answer before?
No, remember, it can be a cumulative effect. So eating it as a young man, it will accumulate. So all the effect will accumulate.
So what should you do to people like you, young men? We don't want them to die, young people. So what do we do to them? We educate them, not so? Yes?
Yeah, education, you're right. So it's health education.
Yes, thank you.
Okay, thank you. So my question is for Dr. Fisher. And I want to commend both presenters for excellent presentations. So Dr. Fisher, I was listening with interest in terms of the global prevalence of chronic kidney disease, which I think was 9%, and then our prevalence was, I think, between 7 and, right. And you alluded to it, but I just wanted you to clarify, because you had mentioned that this was linked to the glomerular filtration rate and that there is a broader kidney disease. So could you just clarify that a little bit more, please?
Right. So that 9% includes people with albuminuria, right? So the definition of CKD is not only low GFR, meaning GFR under 60, or albuminuria, right? So if the population-based, that 9% includes people with amenorrhea, which may not have a low GFR, if you understand what I'm saying. So the 7.6 is actually high because you can't compare it to 9% because that's the overall definition of CKD, which would include people with normal GFR.
So as a follow-up, would you have, just using the EGFR, would you have figures for other countries, and do we compare?
It's variable because it's hard to define CKD. In the US, the total rate of prevalence is 12% for CKD overall, and I believe it's about 6 or 7% for GFR under 60. But the problem is that CKD, recent data published from just long cross-sectional studies, it's very hard to estimate CKD prevalence because it's a very silent disease, right? Most people are not testing for CKD, right? So even when you look at, US which has very good CKD data and registry, that is an underestimate. So the 7 point, what is concerning is that two things. So one is that we have a high rate of advanced disease, meaning that 40 in 10,000 population have CKD stage 5 based on this, which means you need renal replacement therapy, right? The second thing is that we have to remember that we have a high rate of sickle cell disease, in addition to trait. And sickle cell disease, the GFR is not a good measure of function. So you're also excluding those patients that a GFR of 15 may, or even 20 may mean dialysis for them. So the other thing you have to exclude is there's things that increase progression. So progression from one stage to the next is higher in patients who are predominantly Black. So I think that, yes, the 7.6 is lower compared to 9%, but there are other, it's actually higher when you take, it's just low GFR. What we need to do to further define CKD risk is to analyze the amenorrhea data. That may give us some more information. And what's really important is that amenorrhea, or CKD, is not just a disease of the kidney. It's a leading cause of cardiovascular death. So you're not just thinking of the kidney, you're thinking of cardiovascular outcomes as well.
Thank you.
Hi, Doc. Just a follow-up question. In your research, the sort of demographic distribution. Yes.
In terms of, I'm not sure.
Of like, say, race, is it predominantly among Blacks?
All right, let me mistake that. So there's a lot of genetic admixture in Jamaica, right?
Yes.
And in the Caribbean. We did not collect data on race, if I remember correctly.
When you look globally.
Like globally, right? People of African descent are more likely to have kidney disease, incident kidney disease, and they're about 8 times more likely to end up on dialysis compared to Caucasians. The reason for that is a gene, the thought for that is a gene called APOL1, which may explain the high rates of hypertension-related kidney disease in African Americans and people of West African descent, so people from Ghana, West Africa, of which we are direct descendants of. In Jamaica, there's quite a bit of genetic admixture, and we don't have the rates of APOL1 related, or at least the prevalence of APOL1 high-risk alleles. That's something that we should study.
Thank you to our presenters. Can we take one more question? And this will be our last question for a segment.
Thank you. And again, I just want to join the team in commenting. Excellent presentation, research subtopics. I just wondered, I think I may have, my appreciation is that smoking is a risk amplifier for CKD. And I note that it seemed not to be so. Can you comment on that?
So I'm not sure. Maybe the overall just low rate of smoking in general in the population, and we may not capture some other types of smoking that people are doing now, like vaping, which has increased potentially since we've done this study. So I think this was in 2016-17. I think potentially looking at, especially amongst our younger patients, we might find an association. But there is definitely an association with tobacco use, and especially people with diabetes increases your risk of kidney dysfunction.
All right, thank you to our presenters. So we'll move to our next two presenters. We'll ask you to stay as support for our final presenters. Our first will be Dr. Melissa Royal. She's a champion for children's health and wellness. She completed her Doctor of Medicine at the University of the West Indies, Mona, and works as a pediatrician in the Accident and Emergency Department at the Bustamante Hospital for Children, the island's only tertiary pediatric hospital. Then we will have Mrs. Heather McGraw. She is a family nurse practitioner assigned to the St. James Public Health Services. Since 2011, Ms. McGraw has been coordinating the Non-Communicable Diseases Program. She's a member of the International Council for Nurse Practitioner, Advanced Practice Nurse, Core Steering Group, and became the Global Membership Officer in 2021. She was one of the first international ambassadors for the American Association of Nurse Practitioners. Mrs. McGrath has co-authored guidelines on advanced practice nursing and prescriptive authority for nurses. Dr. Royal will now come, and immediately following will be Nurse McGrath. Please put your hands together for final two presenters.
Good afternoon, everyone. I would like to thank the presenters for inviting me to present today. On the impact. So my presentation is on the prevalence of hypertension in adolescents 10 to 14 years old in Kingston and St. Andrew, Jamaica. Just a moment while we await the slides.
Good afternoon, everyone. I would like to thank the planners for this National Research Committee for allowing me to share my research findings entitled The Association Between Social Factors and the Prevalence of Diabetes Mellitus in Urban Jamaica. This paper was done in partial fulfillment of the postgraduate diploma in health research and epidemiology, and I would like to thank my supervisors and authors and institutions which are projected on the screen. By way of introduction, according to the International Diabetes Federation, in 2021, approximately 531 million adults were estimated to be living with diabetes mellitus globally. Of this number, 75% of these individuals were living in low-income countries. In Latin America and the Caribbean, there's a projected 148% increase in the number of persons living with DM by 2030. Right here in Jamaica, 11.9% of the population were estimated to be living with diabetes mellitus during 2016 to 2017. Diabetes mellitus is a progressive disease which requires support from family and friends, especially in developing countries where medical services are limited. The global increase in diabetes mellitus prevalence confirms diabetes mellitus as a significant global challenge to the health and well-being of individuals, families, and societies. Evidence from high-income countries suggests an association between social factors and the prevalent DM, but research in the Caribbean is limited. The aim of my research was to evaluate the association between social support, education, and community property value with prevalent diabetes mellitus in urban Jamaica. By way of methods, a secondary cross-sectional analysis was conducted using data collected in the 2018 to 2019 from the Cardiovascular Health in Urban Community study. This study evaluated ideal cardiovascular health and the effects of psychosocial stress, social networks, and social support from participants in the parishes of Kingston, St. Andrew, St. Catherine, and St. Thomas. Written permission was obtained from the principal investigator to use the data, and the University of the West Indies Ethics Committee provided ethical approval, and all participants provided written consent. 841 persons provided consent for the study. A complete case analysis was conducted to exclude participants with missing data for the variables of interest. The final sample used for the analyses included 763 participants. The outcome variable was diabetes mellitus, which was defined by a fasting blood glucose of greater than or equal to 7 millimoles per deciliter of blood, or doctor-diagnosed diabetes mellitus. And the exposure variables are projected on the screen, which include education, social support, and community property value. The other variables, I speak about the confounders of age, sex, employment, body mass index, and hypertension. Height, weight, blood pressure, and fasting blood glucose were measured using standard protocols. Education, doctor-diagnosed diabetes mellitus, and hypertension were self-reported. Data on community property value were obtained from the National Land Agency. Social support was determined from responses on the number of friends, 1, in their social network, 2, who were willing to offer a small loan, and 3, who could provide advice. And principal component analysis was used to create a social support score by combining all 3 variables for social support. The Stata version 17 software was used to conduct the following analyses. Percentage distributions for the categorical variables of education, land tertile, employment, and hypertension were computed. The means and standard deviations for the continuous variables of social support, age, BMI, blood pressure, and fasting blood glucose were generated. The medians and interquartile ranges for network size, instrumental support, and informational support were also assessed. The person's chi-square test was used to examine associations amongst the categorical variables, while the independent sample t-test was used to assess differences in means for the continuous variables. The multivariable logistic regression was used to assess the association between social factors and prevalent diabetes mellitus. And a statistical significance was defined as p less than 0.05. By way of results, when we examined the summary characteristics of study participants by sex, we found that females had a higher BMI than the male counterparts. If we look at the prevalence of diabetes status by sex, we found that 15.5% were male, 18.5% were female, corresponding with an overall prevalence rate of 17.5% with a 95 confidence interval of 15 to 20%. Now let us examine the prevalence of diabetes mellitus by age, and we found that as age increases, the prevalence of diabetes mellitus also increased with a higher 1.9% in the 75 and over age group. When we looked at the distribution of social support characteristics by sex, we found that males had a higher median network size and informational support. And also, males also had a higher social support score compared with their female counterparts. Now look at the proportion of participants in categories of education, land value total, employment, and hypertension by sex. We found statistical significance for employment and hypertension. So distributions of employment status were different for males and female. However, within each sex categories, most participants were employed. And sex-specific differences for hypertension were also revealed. We now look at the adjusted odds ratio for diabetes status among study participants, and we use sex-specific models. And we found statistical significance for education, age, and hypertension. There was no association between social support score and diabetes. We also found that males who had attained more than a high school education were 76% less likely to have diabetes. And males in community in the middle or upper tertile of land value was at a higher odds of having diabetes mellitus, but this did not achieve statistical significance. So we thought that land value appeared to have a little effect on the odds of having diabetes among women. And female with hypertension were at increased odds of having diabetes compared to those who did not have hypertension. So when we had adjusted for the confounders, we found no association for social support or community property value. So we found that males who had attained more than a high school education were 76% less likely to have diabetes. And females with hypertension were at increased odds of having diabetes compared to those without hypertension. So the key findings were higher educational attainment was inversely associated with diabetes mellitus among men in urban Jamaica, but social factors such as community property value and social support were not. Further research is warranted to explore these associations in rural settings and their impact on the other outcomes, including diabetes mellitus, complications, and survivorship. And one strength was the population-based study was designed to be representative of the general urban population in Jamaica. And we had two limitations, which include estimates were not weighted, which limits the generalizations of the findings. And the sample size was relatively small, particularly for men, and therefore underpowered to show some association. And these were my references. Thank you.
Thank you. Good afternoon again, everyone. So yes, I'll be presenting on the prevalence of elevated blood pressure and hypertension in adolescents 10 to 14 years old in Kingston and St. Andrew. And this was a pilot study that was done in partial fulfillment of the Doctor of Medicine postgraduate program. Declared that there were no conflicts of interest. So blood pressure gives us a measure of the pumping ability of the heart and the health of its associated vessels and organs such as the brain and kidneys, which are important for survival. We're aware that the normal blood pressure for adults is less than 120 over less than 80 millimeters of mercury, but for children and adolescents, it varies with height, sex, and age, and there are tables for this. So a normal blood pressure for children and adolescents will be less than the 90th centile for their height and age. So we sought to look at elevated blood pressure and hypertension in the pediatric population because it has been shown in previous studies to persist into adulthood. And there was a dearth of studies that had looked at this in children worldwide. We know that in terms of the morbidity of elevated blood pressure and hypertension, there is evidence of end organ damage in childhood, which has been seen to progress over time. And this is manifested by increased left ventricular mass or hypertrophy and carotid intima media thickness, as well as pulse wave velocity. Carotid intima media thickness is a measure of atherosclerosis, and pulse wave velocity gives us a predictor of myocardial and infarction and stroke later on in life. So we set out to determine how prevalent elevated blood pressure was in these early adolescents. WHO defines adolescents from 10 to 19 years old. And we wanted to investigate the socio-demographic and anthropometric factors that were associated with elevated blood pressure and hypertension. So this essentially was a cross-sectional study that was done in primary and high schools that were randomly selected from all the schools in Kingston metropolitan region. Once they had a population of greater than 400, then they would be on a list that we obtained from Ministerial of Education and randomly selected these schools. We contacted the schools and gained approval from the institutions, and this is after getting ethical approval from the University of the West Indies. There were requisite consent and assent forms, consent from the children to say yes, they're willing to participate, well, assent, that they were willing to participate after we retrieved the consent forms from their parents. That leads us to our exclusion criteria. We wanted to know the prevalence of essential hypertension. So if we asked and they said that they have a secondary cause of hypertension, such as coarctation of the aorta or endocrine disorders or even renal disease, they formed part of the exclusion criteria. If we did not receive a consent or an assent from the parents or the children respectively, then they were not allowed to participate, as well as if they were a ward of the state. So in terms of the methods and what we had done for these children, there were anthropometric measurements. Their weight, their height, and their body mass index was calculated. We looked at their blood pressure, which by international standards was done a series of 3 times. And the last 2, there was an average of the last 2 blood pressure measurements. And that was taken to be the blood pressure for that visit. We also, by way of questionnaire, looked at the socio-demographic variables to see if there was any association with their elevated blood pressure. And we inquired, as mentioned earlier, of their past and personal medical history. Obesity, as a reminder, is defined as a BMI of greater than the 95th percentile. So in terms of the definitions for blood pressure, most guidelines have followed the 4th report on the diagnosis, evaluation, and treatment of high blood pressure, and this has been the standard of care up until 2017. And so previously, the categorization of hypertension was that of pre-hypertension that saw a systolic and or diastolic blood pressure of greater than 90th centile, but less than the 95th centile for sex, age, and weight, or if their blood pressure was greater than 120/80, but less than the 95th percentile. So those were considered pre-hypertensive. For stage 1 hypertension, if the blood pressure fell between the 95th percentile but less than the 99th percentile plus 5 millimeters of mercury, they would have fulfilled the criteria for stage 1 hypertension. And anything over 99th percentile plus 5 millimeters of mercury fulfilled the criteria for stage 2 hypertension. So in 2017, the American Academy of Pediatrics published clinical practice guidelines that really sought to answer the question, are we missing children based on the previous criteria with high blood pressure or elevated blood pressure based on the guidelines that were done before? And they essentially had lower cutoff values. So elevated blood pressure was defined as greater than, for the 1 to 13 years, 90th, but less than 95th percentile, or 120/80th to the less than 95th percentile, whichever is lower. And stage 1 hypertension was greater than 95th, but less than the 95th plus 12, and they had lower cutoffs in terms of 130/80 to 139/89. So whichever was lower fulfilled that criteria. And for stage 2 hypertension, if their blood pressure was greater than the 95th percentile plus 12 millimeters of mercury, or greater than 140/80, which coincides with the American Heart Association categorization for hypertension. And for those 13 years and older, if their blood pressure was 120 to 129/80, and stage 1, 130 to 139/80 to 89, and stage 2, greater than 140/90. So our data was analyzed with descriptive analyses that utilize the chi-square method for categorical variables and the means for continuous variables, and independent t-tests to determine the associations between continuous variables, and logistic regression was used to determine the impact of various factors on the likelihood of having elevated blood pressure or hypertension, and statistical significance was determined at the 5% level. So after we sent out letters of invitation to the parents, that was 513, of those we received 299 parental responses, and 23 of our children met the exclusion criteria. So that left 276 of respondents that we collected data and analyzed. We sought to find out how many of our children had visited a doctor or nurse in the past year as a proxy for the children who may have had screening. And yes, 77.7% agreed to or said that they had visited a health practitioner, but only 39% had their blood pressure checked in the past 12 months. In terms of the anthropometry and the body mass index, just about 49.6% of our correspondents had achieved, or we found that there was statistical significance for those who had their weight checked in terms of normal weight, underweight, overweight, and obese, and a significant portion of them were found to be within the mean of their height, on average 154 centimeters, and about 21 of our population was found to be overweight or obese. And this is what this slide has depicted. So in terms of the visits to measure their blood pressure, if they had elevated blood pressure on visit 1, we went back to the schools in about 2 weeks to redo their blood pressure, and if they still had elevated blood pressure at that time, a third visit to the school was done. So it was found overall, those who had either elevated systolic and diastolic or both, that 6.1% of them had elevated blood pressure, and then 2.5% had elevated blood pressures at visit 2 and visit 3. In terms of those who were actually diagnosed with blood pressure, 1.8% had elevated or systolic hypertension by the fourth report, and 2.5% met the diagnosis for hypertension by the 2017 guidelines. In terms of, very significantly, what we found was that those children who were either overweight or obese, together up to 30% of them, those who had elevated blood pressure were either found to be overweight or obese, and this was significant in the population that we had seen. And this also played out in the 2017 guidelines. So in conclusion, elevated blood pressure and hypertension are early concerns for Jamaican adolescents, and this needs to be checked for the children, and it's positively correlated with either being overweight or being obese. And from our study, we have seen that there is suboptimal screening of the blood pressure by healthcare professionals, which needs to be done for our younger population. I thank you.
right, we are opening up for questions for our presenters. Are there any questions? Do we have questions from our online participants? We want them to feel engaged. We want them to know that we're listening to them, that you're here. And I think I'm going to give a gift to our online presenters, our online participants. I have a question and I will give a gift to the person who answers in the chat. I hope somebody's monitoring the chat and listening to this question. Are you ready online? This is for online, okay. I want you to give just three risk factors for NCDs that have been mentioned over and over and over again in our presentations and earlier today. Just three. Dr. Grant, you looking for them? So you can give me the first name of the person that gives three. And I want you to name the first person and give me their answer. And we'll let them know if they're going to win a lovely umbrella. Only for those online. And if we have two persons, we'll give two umbrellas. And just for the men, if you're there, we have lovely male umbrellas and lovely female umbrellas. We want to know that you're listening and that you're here.
The first person that answered was Rachel Lee Francis.
Yes, we're clapping Rachel Lee Francis, and we want to know where she's from, what region or institution.
I'm not seeing her information yet.
Okay, and her answer?
Diabetes, hypertension, and chronic kidney disease.
Oh, wait. We said risk factors, Rachel.
First person that
we're gonna
answered.
We're going to move ahead, Rachel.
Okay,
we
so
want risk factors for NCDs.
The next person was Tracy Thomas Gale.
Tracy,
and she had obesity, inactivity, and unhealthy diet.
We had two. I missed the third. Physical inactivity, unhealthy diet, and
obesity.
Okay, we'll work with that. All right, give Tracy. Is there a third person? Because we're ready to give away two. Look if there's a male. We want to know that our males are listening, are participating. So while we're waiting on the male, do we have any questions for our presenters? We'll take one. Dr. Grant.
Yes, I just want to once again congratulate our presenters for really very interesting presentations. The presentation that dealt with the diabetes in the urban areas, I had a question with respect to the social, I'm trying to remember the terminology that you used with, for males, and that males were higher than females. Do you recall what I am alluding to? It was a social support in males was higher than in females. So I found that quite interesting. I was wondering what you thought about that, how you could explain that, and is that something that is unique to your population as opposed to the wider population?
Thank you for your question. During my research, I also found that results somewhere in the USA. But from a Jamaican standpoint, if we look back, males are sometimes they're at the bar. The women are always left at home, have to be rearing the children, so sometimes there's less time for them to integrate. But men, they're at the bar, they have social, they have football game that they are allowed to go to, while the women are left at home, have to cook and take care of the children. So possible there are some of those factors which really contribute to this result in Jamaica. Thank you.
Go ahead.
I was observing, and the persons were indicating why the interest regarding the property value. When you looked at the property in relation, why that interest came up?
Oh, okay. For that variable, we actually got the information from, as I mentioned, National Land Agency. So what was done, they actually had a median property value for different enumeration districts within the and communities. And from that property value, they were somewhat quoted in Jamaican dollars. So for the lower land turtle, it was less than $1 million. For the middle land turtle, it was $1 to $2 million. And for the upper land turtle, it was from $2 million to $9 million. It was actually a middle property value that was used.
Why the no, she said she got it. I got you. That's all right.
This is for the other speakers, so.
Oh, thank you.
Okay. All right. Good afternoon. It's still, is it morning or afternoon? Afternoon. I must say those are very good presentations, very informative. My question is to Dr. Royal. Now you said 39% of the persons who, well, persons would have gotten their blood pressure checked in the last 12 months.
Correct.
I think that was what you had said.
Yes.
And I would want to know, is it that these persons, is it that they went to get medical attention, but the blood pressure was not checked, or they did not go? They did not have a need to go for medical checks.
Thank you for that question. So the visits would have been for a wide range of reasons, either for medicals or for a sick visit. So it was not discriminating why they went to the doctor. It's just whether or not they had need to go to the doctor. So ideally, children who are 3 years and older should have a yearly blood pressure done. But what we found was that even though they went either for a sick visit or a well visit, only about 39% of them had a blood pressure done. So it's really a question that needs to be asked. Have you had your blood pressure checked within the last year? And if the answer is no, even if there is no indication in that moment, it needs to be done.
Okay, thank you. I will just add a follow-up question to that. Excellent presentations, and normally when we take the children to the doctor, we don't normally see blood pressure being taken. So from your research, is it that it should be a requirement as the regular routine that they do for adults?
Thank you for that question. And that essentially is the goal of the study, to highlight the need for children to have their blood pressure done. The minimum requirement, especially by the 2017 guidelines, is that it should be done at least once a year. Certainly, if they have other indications, known to have kidney disease or any cardiovascular disease, anything that would put them at risk of having elevated blood pressure, then it would need to be done more frequently. But for our well children, in order to pick up those before they get to the manifestation stage of non-communicable disease, the goal or the protocol really should be to do their blood pressure at least once a year.
Okay, thank you. So if we go to the pediatrician and they're not doing it, parents can request.
That is correct.
So can we put a jingle to that? Thank you.
Yes, we'll have to work on that.
All right, thank you very much. We are now at the close of our non-communicable disease concern segment. Do we have a second person for our gift? Did we have someone else responding from online?
There was somebody who answered in the question and answer toggle. Dion Harrison said overweight, smoking, and lack of exercise.
All right, great. So we have Tracy and Dion. Give them a round of applause. So we're going to collect their information, and we're going to have the FE units from the NCD units giving them their prize. A round of applause for our presenters again.
So before Dr. Evelyn Carr goes, we want to really thank her for ably leading us through this session. We had 4 engaging presentations, and Dr. Evelyn Carr helped to guide the process and guide the questions. So we want to thank her and hope that she will do this again. Thank you so much.
Hello, I'm Dr. Shin Young-soo. I'm Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
What happened, Aiden? My mama told me I need to come off the tablets. Yes, you should. We need physical activity. Well, that's what the adults say. Adults, I tell you. Seriously though, with physical activity, we will get better grades, better heart health, and improve the bone health. Oh, I heard it will improve memory and overall mood. Yes, it will maintain our weight and lowers the risk for the pressure. Do you know what will lower your self-depression? What?
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
We're gonna get funky, 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 funky. Everybody clap your hands. Clap, 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 clap your hands. Clap, 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 clap your hands. All right, now we're gonna do the basic step. To the left, take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, 2 stumps. Left foot, 2 stumps. Slide to the left, slide to the right. Crisscross, crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. 2 hops this time. 2 hops this time. Right foot, 2 stumps. Left foot, 2 stumps. Hands on your knees, hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out. To the left. Take it back now, y'all. 5 hops this time. Right foot, let's stomp. Left foot, let's stomp. Right foot again. Left foot again. Right foot, let's stomp.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis, to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Do your part to prevent mosquito breeding. Mosquitoes will breed in any container that holds water.
Tightly cover water storage containers such as drums, barrels, buckets and tanks. If this cannot be done, pour cooking oil on the water surface. Punch holes in all tins, plastics and beverage boxes to prevent the collection of water before disposal. Cover all tires or fill with dirt to prevent water collection. Scrub all vases once per week to remove mosquito eggs. Use mosquito repellents to protect yourself from mosquito bites. Dispose of garbage properly by placing in plastic bags and securing properly to prevent water collection.
A message from the Ministry of Health and Wellness.
Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Physical activity defined as bodily movement. You know it beneficial to every student. Chin up, push up, jogging, sit up, feeling lazy, better get up. Physical activity help your mood and memory, make you remember anything, cause it boosts dopamine and serotonin. Target attention, focus, regulate moods. Come learn something. Yeah man, listen young youth. Physical activity, healthier weight, go and exercise. Students hold the faith. The more you do, the more calorie your body use. Calorie deficit, calorie get reduced. Exercise build your bone and make it more dense. A facts we attack, ladies and gents. Physical activity is of the essence, needed like full stop in any sentence. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Physical activity.
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
One, two, three, two more. 1, 2. Adults to 30 minutes activity daily. Love your body, treat your body right. Vegetables, make sure you eat plenty. Children do 60 minutes activity daily. Drink some water when you feel thirsty. Cut down dessert and have a smoothie. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Make sure you know your health status. Go a doctor and get a regular checkup. Chronic disease can slowly creep up. We can lower the risk and live up if we just eat right and get moving. Jumping, running, dancing or skipping. Change the children, them lazy habit. Make them play out the door and put down the tablet. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. After 2, make me hear you say I love me. 1, 2. 1, 2. 1, 2. Jamaicans, love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Jamaica get moving. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. One more time now. Love your body, treat your body right. Love your body, treat your body right. Just eat right. Love your body, treat your body right. Love your body, treat your body right. Listen up. Love your body, treat your body right. Love your body, treat your body right.
The Ministry of Health and Wellness is celebrating Caribbean Wellness Day 2023 with a weekend of wellness. Saturday, September 9. All roads lead to the University of Technology Jamaica for a sweat fest 4 p.m. to 8 p.m. Join the 3K Fun Run Walk, pass through the obstacle course, and work up a sweat with the Sweet Energy Fitness team. Admission free. No sign-up required. Lots of prizes and surprises along with free food samples. Come, get your Jamaica Moves shirt. It's a weekend of wellness. Wow, with the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Protect yourself from the bite of this mosquito.
A message from the Ministry of Health and Wellness.
Good ganja sense, learn more your ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Knowledge is power, youths we need that. Ganja smoking and no pitney thing that. Commercial ganja you farm then you reap. Entrepreneurs and scientists see. Good ganja sense, learn about the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis. Be smart with your ganja, go get a permit. Ganja full of uses, make sure you learn it. Can sell eye drops, it make for eyes. Ganja can boost lives. Good ganja sense, good ganja sense. Learn about the ganja, just be smart with it. Good ganja sense, good ganja sense. We have many uses for the cannabis.
Brought to you by the National Council on Drug Abuse, an agency of the Ministry of Health and Wellness.
This is the Aedes aegypti mosquito that spreads the Zika, chikungunya, and dengue viruses. Search for its breeding sites and destroy them.
A message from the Ministry of Health and Wellness.
We got to be careful when using pesticides.
Alright, Richie. Can I come out to mash up some spraying idea?
Yeah, I go spray them corn there.
So, are the 3 wearing the protective gear?
Why the sun too hot for suit up here, man?
So you'd read the label before you start. Wear protective gears. Your goggles, your respirator, your gloves, and a coverall. At least you did have on a cap. Mix only what you need for the day. Use only on the crops listed. And if some chemical left over, make sure you store it in the original container.
For more information, call the Pesticides Control Authority at 754-9306.
Jamaica is experiencing a dengue outbreak and we need to take precautions to protect our health. What does that mean? It means destroying or treating potential mosquito breeding sites, including water storage, containers, and especially drums. Emptying dish drainers and plant saucers, as well as keeping our surroundings free of solid waste. It also means wearing protective clothing and using DEET containing mosquito repellent. Let's work together to protect ourselves against dengue. Dengue is ordinarily a mild disease. Persons may get a fever, headache, joint and muscle pains. The illness is often resolved through rest and adequate hydration along with paracetamol to treat the accompanying fever. However, on occasions the illness can progress to severe dengue, which can result in organ failure, bleeding, and severe fluid depletion that can lead to shock and even death. Therefore, it is important for persons who are experiencing fever, vomiting, severe abdominal pain, bleeding under the skin, feeling very weak, or getting confused to seek immediate attention. Let us work together to protect ourselves against dengue.
Any food safety incident is one too many. It affects the health of consumers, it affects food trade and everyone involved, from the farmer to the retailer. The Codex Alimentarius is an important building block of having a safer food supply. But everyone involved in the food chain has a role to play to make sure that the food we eat is safe. Codex, FAO and WHO are supporting the establishment of a World Food Safety Day to bring greater attention to this important issue. Join our campaign in supporting annual observance of this important event. All you have to do is send us a video or an image to show your support for this important event.
Hello, I'm Dr. Shin Young-soo, and Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
What happened, Aiden? My mama told me I need to come off the tablet. Yes, you should. We need physical activity. Well, that's what the adults say. Adults, I tell you. Seriously though, with physical activity, we will get better grades, better heart health, and improve the bone health. Oh, I heard it will improve memory and overall mood. Yes, it will maintain our weight and lowers the risk for depression. Do you know what will lower your risk of depression? What?
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
We're gonna get funky, 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 funky. Everybody clap your hands. Clap, 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 clap your hands. Clap, 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 clap your hands. All right, now we're gonna do the basic step. To the left, take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, two stumps. Left foot, two stumps. Slide to the left, slide to the right. Crisscross, crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. Two hops this time. Two hops this time. Right foot, two stumps. Left foot, two stumps. Hands on your knees, hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out. To the left. Take it back now, y'all. Five hops this time. Right foot, let's stomp. Left foot, let's stomp. Right foot again. Left foot again. Right foot, let's stomp.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis, to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Do your part to prevent mosquito breeding. Mosquitoes will breed in any container that
Welcome back. Good afternoon, everyone. I'm Dr. Kemisha Shaw-Kelly, and I'll be taking you through Scientific Session 2, Patient Knowledge and Care. For this session, we have three presenters. Dr. Nadia Bennett, who will be taking us through the relationship between social determinants and medication adherence and lifestyle practices. among persons with hypertension in Colombia and Jamaica. Next, we have Dr. Sophia Rado, who is online, and she'll be taking us through the prevalence and determinants of medication adherence among persons with type 2 diabetes mellitus attending Cayman Islands Health Services Authority GP clinics. And then we have closing this session a presentation by Dr. Laurie Ann Lyle Miller, who will be taking us through the knowledge, attitude, and practices towards stroke prevention and management among adults 18 years and older in rural and urban communities in Jamaica. So we'll be having our first two presentations, then question and answer. And I'll be just doing the introduction for our first two presenters. Dr. Nadia Bennett is a lecturer and the program coordinator for the Masters of Science Epidemiology program at the Caribbean Institute for Health Research, Epidemiology Research Unit at the University of the West Indies, Mona. She is a consultant in internal medicine and a co-director for the Cochrane Caribbean Geographic Group. Her career is centered on the Caribbean people and aims through research to improve health of those with the chronic non-communicable diseases and attribute to building the research capacity in the Caribbean. Next, Dr. Sophia Rado is originally from Germany, where she studied medicine at the Johannes Gutenberg University and trained at the Department for Diagnostic and Interventional Radiology. Upon her arrival in the Cayman Islands, she enrolled in the family medicine program offered by the University of the West Indies, Mona. In 2021, she was awarded the diploma in family medicine with distinction. She recently completed her Doctor of Medicine in family medicine. Please make welcome our two presenters, but first, Dr. Nadia Bennett.
All right, good afternoon, everyone. I'd like to thank the NHRC for allowing me to share with you some of our work on behalf of the CATCH study, which is a Caribbean and South American team-based strategy to control hypertension team. As mentioned, we'll be looking at the relationship between social determinants, specifically at socioeconomic status and access to food, and medication adherence and lifestyle practices among persons with hypertension in Colombia and Jamaica. So just to say, the investigators have no conflicts of interest related to this study, and the CAT study is actually a multi-country collaborative effort between investigators in Jamaica at the University of the West Indies, in Colombia at the University of Santander, as well as Tulane University and a project team from the National Institutes of Health. So the overall aim of our study really is to measure implementation and effectiveness outcomes of implementing and scaling up a team-based strategy for blood pressure control in Colombia and Jamaica. We are currently in the 4th year of a 6-year study, which is divided into 3 phases. Phase 1, which we conducted a needs assessment phase and is now complete. We established a community advisory board, obtained feedback from stakeholders via interviews, focus groups, as well as surveys of patients, the results of which has now informed phase 2, which is now ongoing, and consists of the team-based intervention in primary healthcare clinics, and lessons that we learned from this phase 2 will go on to phase 3, where the team-based intervention will be scaled up nationally. So I will be presenting on one aspect of the CAT study, whose objective is to determine the association between food insecurity or access to food and adherence to medication and healthier lifestyle practices among Jamaican patients in Colombia and Jamaica. So just as an introduction, medication adherence and healthy lifestyle choices have been shown to mitigate against hypertension complications, and individuals with poor access to food and other socioeconomic markers of poverty are at increased risk of non-adherence to medication as well as healthy lifestyle choice recommendations. So food insecurity is defined generally as limited or inadequate access to food, and given the importance of dietary habits in prevention and management of hypertension, food insecurity is a significant social determinant of health that can have far-reaching health consequences. So by identifying the social factors that are associated with a higher adherence with medications and lifestyle recommendations, we can inform interventions to improve blood pressure control. So for our methods, participants the results that are being presented are from the cross-sectional survey of hypertensive patients conducted in Jamaica and Colombia. So although the same data collection tool was used in both Jamaica as well as Colombia, there are a few differences in recruitment because of the differences in the healthcare systems. So in Jamaica, we recruited participants from 10 primary care clinics, where our research assistants visited the clinics on chronic disease days through quota sampling to identify equal number of male and female as well as urban and rural participants. Participants were then at those visits given information on the study and then later contacted to complete consent as well as scheduled telephone interviews. In Colombia, participants were recruited from 4 primary care clinics where electronic health records were used to identify hypertensive patients in clinics. An equal number of participants, as well as male and females in rural and urban settings, were recruited. Their research staff contacted patients via telephone as well and provided information on the study, consented participants, and conducted telephone interviews. The questionnaires were administered using the REDCap software. So where medication adherence is concerned, we use the Impact MAS score, and participants were asked 2 questions. Over the 7 days, on how many days did you not take any blood pressure pills, as well as over the 7 days, on how many days did you cut back or not take the full dose of your blood pressure medications. So based on a sum of the scores that are displayed here, the participants' individual scores could range between 0 and 3. So for the purpose of this presentation, the outcome variable is expressed as a binary variable where we're reporting a high adherence score of 6, in which participants in answer to both questions neither cut back on their full dose of medications nor did they miss any medications in 7 days preceding. When we're talking about the healthier lifestyle outcome, participants were asked the following questions and then given a score of 1 each if they answered yes. Are you currently eating salt, exercising regularly, decreasing alcohol consumption, or eating at least 2 servings of fruit per day or 3 servings of vegetables per day? They are then classified once again as a binary outcome variable as favorable if they scored 3 points or unfavorable if they had less than 2 points. So for food insecurity, it was measured using a modified USDA food insecurity instruments, and patients were asked if the food that they bought didn't last, or if they did not have enough money to purchase more, or if they couldn't afford to eat healthy meals with more fruits and vegetables, and they answered if it was true most of the time, some of the time, or never true. So if they answered yes to A or B, they were deemed to be food insecure. So we use weighted estimates in all analyses, and weights were determined by assessing the joint distribution of age groups, sex, and residential areas within respective target populations of each country. We use logistic regression analysis to assess the relationship between food insecurity and medication adherence, as well as unfavorable lifestyle practices. So for the results. So in Table 1 here, participants from Jamaica were younger. They had a mean age of 61 years compared to Colombia, where the mean age was 67 years. Jamaicans had longer duration of hypertension of 16 years versus 11 years. We had lower education status than did Colombian participants, where 40% had less than high school education compared to 29% of participants in Colombia. And 18% of Jamaicans had greater than high school education as compared to 35% in Colombia. When we looked in Jamaica, participants were in full-time or part-time employment 52% of the time compared to Colombia, but they had also had a high proportion of participants who were unemployed, where we had 29% were unemployed compared to 10%. So just quickly, looking at food availability in Jamaica and Colombia. Jamaicans compared to Colombians had poorer food insecurity, right? So 20% of Jamaicans compared to 6% of Colombians, the foods did not last, and 32% of Jamaicans said most of the time they were not able to afford healthier foods compared to 6% of Colombians. When we looked at lifestyle factors in Jamaica and Colombia, for healthy lifestyle choices in Jamaica and Colombia, they were actually similar in terms of eating less salt, decreasing alcohol, and not smoking, but they were quite different when Jamaicans were less likely to exercise, consume adequate quantities of fruits or vegetables. So when we looked at medication adherence, as we had mentioned before, Jamaicans were more likely to have low medication adherence score than were Colombians. So in our logistic regression models, in Table 2, we're looking at the odds of having low or medium adherence scores among participants who were not food insecure, that is, those who had better access to food, and we found that it was lower than those who were food insecure in unadjusted models, but when we compared them to in adjusted models for age, sex, country of origin, rural, urban status, duration of hypertension, and education and employment, we found that there was no difference between the two. When we're looking in Table 3, the odds of having less favorable lifestyle practices among participants who were not food secure, that is, those who were food insecure or had better access to food, it was lower than those who were food insecure in unadjusted models. And this relationship remains statistically significant when we adjust it for the same age, sex, country, rural, urban status, duration of hypertension, education, as well as employment. So in summary, food insecurity was common in both Jamaica as well as Colombia. Jamaicans were more food insecure than were Colombians, reporting that their food was less likely to last and that they were less able to afford more healthy foods. In addition, the Jamaican respondents reported less consumption of fruits and vegetables. Colombians were more likely than Jamaica to adopt healthier lifestyle practices, and medication adherence was better in Colombia when compared with Jamaica. So we can say that the impact of food insecurity based on our analyses on medication adherence in Jamaica was not significant, but the impact of food insecurity and adherence with healthy life behaviors was statistically significant when those who were food insecure were less likely to have healthier lifestyle choices. So thank you for your attention.
Thank you. I'm just checking. Dr. Rado, you're hearing us? You can now go ahead and share your slide.
Can you please just let me know if you can see it in slideshow mode?
Yes, we're seeing. You can go ahead.
Fantastic. Okay. Good afternoon, everyone. My name is Dr. Rado, and today I will be presenting on the prevalence and determinants of medication adherence amongst persons with type 2 diabetes mellitus attending the Cayman Islands Health Services Authority GP clinics. I'm dedicating this presentation to the late Dr. Norman Waldron, who sadly passed away just a few weeks ago. Diabetes has been recognized as a global major health issue. According to the International Diabetes Federation, there were close to 500 million people affected by diabetes worldwide, and approximately 50 million people affected in the North America and Caribbean region alone. The holistic management of diabetes includes patient education, non-pharmacological and pharmacological measures. It has become clear in recent years that medication adherence is one of the major cornerstones of diabetes management, as it seems to predict future glycemic control, and poor adherence has been associated with poor outcomes. As it relates to the Cayman Islands, data from the Cayman Islands census conducted in 2021 show that diabetes is one of the 3 diseases with the highest incidence in the Cayman Islands. In the information collected during the last chronic disease risk factor survey conducted in 2012 showed that, and I'm quoting, most persons diagnosed with diabetes mellitus reported taking oral medications, while a smaller percentage reported taking insulin. In preparation for this piece of research, a literature review was conducted, and in conclusion it could be summarized that medication non-adherence in persons with diabetes is a global health issue. Medication adherence results vary starkly in the literature reviewed, and many biopsychosocial factors have been found to affect medication adherence. However, no data on medication adherence in persons with diabetes or factors influencing adherence have been published specifically for Cayman to the best of our knowledge. And in the light of diabetes being one of the biggest local health threats, detailed local research remains necessary. The aim of this study was to assess the prevalence of self-reported medication adherence in persons with type 2 diabetes mellitus on Grand Cayman and to identify factors that influence adherence. The working hypothesis was that the majority of persons with type 2 diabetes mellitus attending the Cayman Islands Health Services Authority or CIHSA GP clinics on Grand Cayman are non-adherent with their diabetes medications. With regards to operational definitions, type 2 diabetes mellitus was defined as doctor diagnosed as documented in the CIHSA electronic medical record. Medication adherence was self-reported using the 11-item adherence to refills and medication scale in diabetes, more on that too later, and glycemic control was defined as the last HbA1c laboratory value within the participant's EMR during a 12-month period. According to the American Diabetes Association, diabetic patients can be seen as controlled if the HbA1c value is below 7% and uncontrolled if it is 7% or greater. A quantitative cross-sectional study design was chosen and the study was nested on Grand Cayman in the Cayman Islands. The study population consisted of adults with a doctor diagnosis of type 2 diabetes and having been registered at any CIHSA GP clinic on Grand Cayman within a 12-month period. This slide gives you an overview of the inclusion and exclusion criteria. I'll break it down for you really quickly. Only non-pregnant adults who have a doctor diagnosis of type 2 diabetes mellitus only, no other types of diabetes were included, who are on anti-diabetic medication, who have an HbA1c value documented, and who have been registered at any CIHSA GP clinic on Grand Cayman were included. A minimum sample size of 252 participants was calculated and a systematic sampling approach was used.
Dr. Rado, are you hearing us?
Below 0.05 was considered significant. Approval to conduct the study was obtained from the Mona Campus Research Ethics Committee and the Cayman Islands Ethics Committee at the Cayman Islands Health Services Authority. And prior to participation, all participants were asked to provide informed written consent. The results. A total of 254 data sets were included in the analysis. The majority of participants were female and the median age was 64.5 years. When disaggregating the data by sex, there were statistically significant differences found between sex and age group, ethnicity, relationship status, education level, but not monthly income. With regards to the ARMS-D tool, good internal consistency reliability with a Crumbux alpha of 0.821 was found. Actual scores ranged between 11 to 36, and for reference, the ARMS-D tool has a potential score range of 11 to 44, with lower scores indicating better adherence. The median score found was 14 with an interquartile range of 5. And for further analysis, the tool was categorized into the two categories: perfect adherence, defined as an ARMS-D score of 11, or non-adherence, defined as an ARMS-D score of greater than 11. Using this categorization, 23.9% of participants were categorized as reporting perfect medication adherence, while 76.1% were categorized as reporting non-adherence to their diabetes medications. The overall majority of participants in both medication adherence groups had HbA1c values in the uncontrolled range of 7% or greater, and there were no significant differences found between those groups. Due to time constraints, I'm not able to show you all results of the bivariate analysis. However, statistically significant variables from bivariate analysis were entered into the logistic regression model to ascertain their effects on medication adherence, and retinopathy approached significance in bivariate analysis and was hence included. In multivariate regression, a positive independent association between medication adherence and diabetes duration was found, with persons reporting having had diabetes for 10 or more years being more than 3 times likely to have perfect medication adherence. A similar result was found for regular exercise, with persons reporting regular exercise being more than 3 times likely to have perfect medication adherence. And an independent negative association was found between out-of-pocket pay and medication adherence, with persons reporting having any out-of-pocket pay for their medication being 77% less likely to have perfect medication adherence. Let's quickly discuss the results. A median score of 14 was found for the ARMS-D tool, which is in line with previously published papers, as was the low prevalence of self-reported perfect medication adherence. However, these data may be seen concerning in the Cayman context, given that the overwhelming majority of residents have at least minimal health insurance. District clinics are located throughout the island. There are short travel times to the clinics. There are short wait times for appointments, and medication is readily available. Other factors seem to actually play a bigger role here. I also want to point out at this point that by categorizing the tool into perfect and so-called non-adherence, we are left with a very heterogeneous group of so-called non-adherent persons that certainly require more investigation into different levels of non-adherence and barriers towards medication adherence. Also, it is hard to compare the underlying data with other regional data on medication adherence because those data vary starkly due to different assessment methods used. Interestingly, there were no significant differences between medication adherence groups and level of glycemic control found, which is somewhat contradictory to previous literature. However, differences may lie in how glycemic control was assessed, how medication adherence was assessed, and the study populations investigated. An independent positive association between diabetes duration and medication adherence was found, and possible explanations include persons who had diabetes for a longer time might have established a medication taking routine and see it as integral parts of their lives, versus developing first complications from diabetes and hence being more aware of having to take their medications, or also benefiting from previous and ongoing diabetes education. An independent positive association was found between medication adherence and regular exercise. A possible explanation might be a higher level of individual responsibility that both activities require, and if they do one, they also do the other. And lastly, an independent negative association was found between medication adherence and any out-of-pocket pay for medication, which is in line with findings from other studies. In conclusion, the prevalence of perfect medication adherence was 23.9%. The prevalence of non-adherence was 76.1% in this study. There were no significant differences between medication adherence groups and level of glycemic control. Independent positive associations were found between perfect medication adherence and longer diabetes duration and regular exercise. And an independent negative association was found between perfect adherence and any out-of-pocket pay. Those are the references used for this presentation. I thank you all very much for your attention.
Thank you so much. Two very informative presentations indeed. So we're now at the point for question and answers. The floor is now open for any comments or questions. Just to check, is there any question online? No? Any question here? Okay. The mic.
Thank you. Thank you. No. Thank you for your presentations. You were showing us at table 3. We didn't see it, so we're not sure about the table 3 from the first presenter. Okay. All right? So there was a question there. Now, for Colombia and Jamaica, what do you think made the difference? Is that they have more food in Colombia? Or they have more job opportunity in Colombia? What was the difference that you would have noted in your research?
So you're asking the difference in adherence between Colombia and Jamaica is the question, and
yes,
and what
because
we think might account for that.
This insecurity, because they had less food, the food finished quicker in Jamaica compared to Colombia. I think I hear something like that. Sir, can I see her, please? Can I see the? Yes.
So
yes. Is that true? Because I thought I was paying attention.
Yeah, that is true. So
okay.
there was food security in Jamaica was a lot less than was in Colombia, and it could be multifactorial, could be related to economic status, socioeconomic status. We did see that in Jamaica more people were unemployed than were employed. In Colombia, a lot more of their population, or that was in this particular study, they were actually housewives or retired as well. Part of it as well could be part of the healthcare system and just the systems that exist in Colombia.
So they have a better healthcare system in Colombia?
I'm not saying that they have a better healthcare system. The healthcare system is different. So it's just different healthcare system.
Because sometimes we can look at what they have if we need to improve. That's why I'm asking.
So looking at both of our healthcare systems, it is very different. So we do have, so where the Colombians are concerned, they have a national health insurance policy where pretty much everybody has health insurance. It's a combination of both private as well as public, depending on where it is that you work. I don't quite understand exactly.
Now we are talking, because this information is critical for me to process the analysis. All right? Thank you.
Okay.
Thank you for that question. If there is no other question, I'm going to move next to our next presenter, Dr. Lori-Ann Lai-Miller. She's originally from the peaceful parish of St. Mary, holds an impressive medical background, having earned a Bachelor of Medical Sciences with honors and a Bachelor of Medicine and Surgery at the University of the West Indies. Her profound interest in neurology was ignited during her time in the stroke unit, leading her to pursue a master's degree in public health to deepen her research involvement. Collaborating with colleagues, she thus embarked on a mission to assess stroke knowledge, attitudes, and practices among Jamaicans. Dr. Lai-Miller's dedication to healthcare and research is an ongoing endeavor driven by the desire to make a lasting impact on the individuals she serves. Please help me make welcome Dr. Lai-Miller as she takes us through the knowledge, attitude, and practices towards stroke prevention and management among adults 18 years and older in rural and urban communities in Jamaica.
Hi, good afternoon, everyone. I am pleased to present to you today a research paper that we embarked on looking at the knowledge, attitude, and practices towards stroke prevention and management among adults 18 years and older in rural and urban parish communities in Jamaica. These communities, St. Elizabeth and St. Andrew. Okay. I can't set it up. Can you bring it closer? Sorry. Okay. On a background, globally, an acute stroke is listed as the second leading cause of death and the third leading cause of death and disability combined. The Interstroke, which is the largest international case control study carried out in 32 countries, found that there are 10 modifiable risk factors accounting for 90% of the population's attributable risk for a stroke. In the Stroke Knowledge in African America review, African Americans were more likely to correctly identify hypertension and stress as the major risk factors for a stroke. Education has been shown to be the most important factors in controlling blood pressure and diabetes. The success of primary prevention measures, as well as timely presentation for medical attention after a stroke, is determined by the public's knowledge and perception of stroke and its risk factors. Now, looking at the background, on August of 2021, an article published in the Gleaner by the Honorable Christopher Tufton reported that stroke is the principal cause of death in Jamaica, with an estimated 7,300 persons suffering from a stroke each year. Because there's a lack of an organized stroke management system, most survivors are left with not only physical disability, but financial burden as well. A mere 40% of persons are able to return to gainful employment, and stroke management costs the average Jamaican about $1.6 million in 6 months, with the annual collective burden being 46 billion Jamaican dollars. Now, we know knowledge is power, so therefore, knowledge of the risk factors, signs and symptoms, as well as a positive attitude towards risk modification and stroke prevention strategies is needed to reduce the incidence of this debilitating disease. It was because of this information that we embarked on a study with the aim of determining the knowledge, attitude, and practices towards stroke prevention and management among adults aged 18 years and older in urban and rural communities within St. Andrew and St. Elizabeth. Our objectives were: 1, to determine the knowledge and attitude towards risk factor stratification of persons with an acute stroke, to determine the knowledge, attitude, and practices towards stroke prevention strategies, to ascertain the knowledge and attitude regarding the signs and symptoms of a stroke, and to determine the proportion of individuals who could identify the 5 major warning signs and symptoms, to determine the knowledge and attitude towards long-term outcome of a stroke, and to determine if socio-demographic factors influence was important regarding stroke risk factors of signs and symptoms. Now, our methodology, we employed a cross-sectional study design looking at 2 parishes, one urban and one rural. Our urban parish was St. Andrew, and St. Elizabeth was chosen as being one of the largest populated urban parishes. 5 communities were randomly selected using a mini-web random picker. Now, based on a United States study, which shows that the knowledge of persons was about 66.2%, that, along with the population of the parishes, a sample size of 342 participants was determined using Daniel's formula. Data collection was done using an original 41-question interviewer-administered questionnaire. Our questionnaire was first pre-tested, and adjustments were made based on feedback given. And the questions collected demographic information, persons' pre-existing medical conditions, signs and symptoms using information from the Interstroke trial, and we also utilized a study done by Hickey in Ireland, where good stroke knowledge was identified as an ability to identify 2 or more risk factors spontaneously. The data was analyzed using SPSS version 23. Statistical significance was determined by a p-value of less than or equal to 0.05, and logistic regression was used to determine independent socio-demographic factors that predicted stroke knowledge. Our results, overview, we were able to collect all 342 questionnaires with a response rate of 96% in St. Andrew and 94% in St. Elizabeth. The median age of our population was the age range, was 18 to 88 years with a median of 37 years, and the plurality of respondents were single. Looking at the health characteristics of the 342 respondents, 70% of the participants reported no chronic illnesses, while 45% of participants over the age of 45 reported they had a chronic illness. Now, this is a table showing our socio-demographic profile, and here you see we did have a median age of 37. We had about similar male to female distribution based on the population of our study. The majority was young to middle-aged. Regarding our educational background, we found that most participants in the rural area obtained a secondary level education, where more people in Kingston were able to attain a tertiary level education. Educational employment status, more in Kingston had income. We found that more people in Kingston had income range between 50 to 100,000, where 20 to 50,000 were more likely for persons in St. Elizabeth. Now, self-reported health characteristics, we found that current smokers, we found more persons in St. Elizabeth smoked, as well as more males smoked compared to females. And prior stroke, only 3.2% of the participants had a prior stroke. And we found that more persons in St. Elizabeth and more males also had a prior history of having had a stroke. Looking at existing illnesses, we found that hypertension and high cholesterol were more prevalent among females and St. Elizabeth, while diabetes was more prevalent among our respondents in Kingston, in St. Andrew, Now, looking at our spontaneously reported risk factors, we found that only 1% of respondents were able to report 7 risk factors spontaneously, while 30% were able to report only 1. And when given a list of answers, only 37% were able to correctly identify all 10 risk factors. Looking at the signs and symptoms, we found that only 47% of our respondents were able to correctly identify 2 risk factors. When given a list, 50.6% were able to identify 5 warning signs and symptoms. Now, we realized that knowledge of risk factors was primarily knowledge of weakness, one-sided weakness, and slurred speech. Those were the 2 most known risk factors. Persons were less likely to identify headache and vision disturbances as a sign and symptom of a stroke. Predictors of good knowledge of signs and symptoms were being female, residing in St. Andrew, and persons who were employed and self-employed. Now, attitude, we found that most participants, 78.9%, thought some people were more likely to have a stroke than others. 37% worried about their personal risk, and 28.4% thought a stroke was fated and hence could not be prevented. Prevention, looking at diet, only 61.1% of respondents reported a healthy diet as a preventive measure, reported knowing a healthy diet was a preventive measure, actually practiced it. And we found this was more prevalent in the older population, which is those over 60 years. Looking at exercise, we found that more males and females exercise, and statistically significant relationship was found for more men exercise as compared to women. 25.1% of those without a chronic illness reported engaged in routine exercise, and 65.7% of those with knowledge of a close friend or family member had a stroke actually exercise. Medication adherence. Of the persons who reported compliance, 71% were female, 44% were over the age of 60, and 53% of persons resided in Kingston.
Health information source, we found that medical doctors, television, and social media were more likely to be employed, with young persons looking more at social media and medical doctors. Middle-aged persons look more at television and medical doctors, and over the age of 60 utilize more medical doctors and television. Limitations or results are based on self-reported data, which is subjected to recall bias and social bias. Cross-sectional design limits the ability to establish causality, and longitudinal studies with qualitative research could provide deeper knowledge and understanding. Our conclusion, there's a crucial need to address the inadequate stroke knowledge, attitude, and practice among Jamaicans. This study identified demographic factors, including age, gender, and geographic location, as significant influences of stroke knowledge, and it emphasized the importance of tailoring educational campaigns to target specific groups. Our recommendation, comprehensive stroke education. Partner with health professionals to ensure up-to-date information is given at each visit, leveraging social media, especially for young persons. Incorporating stroke education in schools, a mobile app to emphasize more healthy practices. Cooperating with media outlets to disseminate stroke education, and continued evaluation to ensure adequate stroke practices are being implemented. These are our authors, and I thank you for your time.
Thank you so much. Very detailed and informative. So the floor is now open for any comments or question. Do we have any question online? Okay. Any question? You do? No? Can go ahead.
Thank you. Okay, thank you very much for an excellent presentation. I was wondering why she was looking at the thing in a critical way, but yes, I found that. So we are empathetic for that, okay? So the glasses was not available, all right? So I'm sure some persons would have been wondering too, so we understand. Now, I heard something, I'm not sure if my ears were not clear. Is it that St. Elizabeth, do you say it's a rural or urban? Rural. Okay. I thought I heard urban at a time. Somebody heard that? Thank you. Yeah. No, we heard it there, but we leave that alone. It was just, yeah. Thank you.
St. Elizabeth was considered because it was one of the more populated rural parishes.
Thank you.
Yes.
Yes, we are glad to hear it like this. And a next quick question now. Looking at the, let me hold this like this. Looking at the last conclusion that you have, attitude, practices, and stroke, will you say we will need to educate them more, or what do you think we should do for persons to be able, because when you tell me about urban and rural, the urban population to some extent are considered to be more knowledgeable. Is that true?
So our study showed that the knowledge base of persons in Kingston was actually better than those in St. Elizabeth. So we thought that at times might be, education has been shown to be one of the strongest modalities to be utilized to improve stroke knowledge and influence persons' attitude as it relates to stroke risk modification, because without complete knowledge of the signs and symptoms and what to do, and knowledge of the stroke risk factors, then we can't modulate people's lifestyle to have them adequately make the necessary changes and implementations to get the care that they need.
Okay, so the urban were far more knowledgeable than the rural.
Urban was more knowledgeable than rural.
Okay, so what do we do to make amends?
So as you saw in one of the later slides, we evaluated what health education modalities persons utilized, and we saw that young people were heavily into social media, though they did utilize medical doctors. So all three age groups utilize medical doctors, but younger persons use social media more, the middle-aged persons use television more, while those over the age of 60 utilize medical doctors more. So you could utilize this information now to target different age groups and use that to influence their education strategy.
Okay, thank you.
Sure.
See another question?
Yes, thank you for the excellent presentation. I just wanted to follow up on that question that was asked. So we are thinking of the ideal in terms of what we will do with respect to social media platforms, etc. But I'm wondering what obtains now. Where is that information taught now in terms of the stroke risk factors? Where is it something that is being disseminated at all in the health facilities, or is it something that we will have to start from scratch?
Knowledge of stroke risk factors?
For the patient, to teach the patient.
Okay, so I think, as we mentioned in our recommendations, I think we did find that younger persons had better knowledge as it relates to stroke signs and symptoms, as well as risk factors, as it related to older individuals and persons over the age of 60. I am thinking, based on our recommendations, that putting this information, teaching younger people, incorporating into our education system from an early age will actually influence persons' educational level and influence their lifestyle on a whole. As you saw from the study, only 47%, I think, of persons were able to identify 7 or more risk factors. Nobody knew all 10 risk factors. And when it came on to signs and symptoms, persons were only able to spontaneously identify 2. Nobody knew all 5 signs and symptoms, so therefore they're not able to act without the information. So I think a focus really needs to be placed on education. We need to start from the very young and then disseminate this information throughout. We can start with social media, we can start with television. Everybody utilizes television as an education modality, all 3 age groups. And then by disseminating the information, hopefully we can elevate our educational level and therefore influence lifestyle and behaviors. Mm-hmm.
Thank you so much. We had 3 excellent presentations, and we're now coming to an end to this session. Thank you so much for your attention as we close this session. You have a question for Dr. Rado? Okay. Dr. Rado, you're hearing us online? There's a question in the chat? Okay, there's a question in the chat for you.
Yes, I'm seeing why the median age of the participants was over 60 years old and what were really reasons to not include younger folks with diabetes. Well, they were included, but the age range actually ranged from the youngest study participant being 20 years old to the oldest being over 90 years old. But remember that the median is the midpoint of a frequency distribution, and in our case, the median was found to be 64.5 years. So yes, they were included, but in this study sample, older persons prevailed.
Okay. Thank you, Dr. Rado. You can come ahead.
So at this point, we want to thank Dr. Shaw Kelly for ably taking us through this session. We do appreciate her moderation. We also have to highlight the excellent presentations as well. And so we just want to say a word of thank you to her.
Hello, I'm Dr. Shin Young-soo, and Regional Director for the Western Pacific World Health Organization. Today, on the World Health Day, I would like to ask you, how safe is your food? Does your country's food safety system protect you and your loved ones? Does it follow international best practice?
Harmful bacteria, viruses, parasites, and chemicals can contaminate food. Every year, millions of people in Asia and the Pacific are affected by diseases that are caused by unsafe food. Unsafe food causes more than 200 diseases, including acute diarrhea, cancer, kidney failure, brain disorders, and chronic malnutrition. Diarrhea is the most common symptom of food and waterborne illnesses, causing some 2 million deaths a year. The risk of unsafe food crossing borders is greater than ever. Trade in food and livestock products in Asia has increased threefold in the past 20 years. Contaminated food can transport disease halfway around the world in a few days. Food safety is a shared responsibility. Countries must work together to prevent foodborne disease outbreaks. Because food safety assurance is only as strong as the weakest link in the food chain. Food safety incidents also have economic consequences. Millions of dollars are lost every year due to food contamination. Consumers lose confidence in the food and stop buying it. Businesses close, people lose their jobs, and exports decline. Food safety must be a priority, from farm to plate. Governments must take responsibility and ensure that all foods comply with minimal food safety and quality requirements. Otherwise, the health and economic consequences may be serious. WHO helps member states build capacity to prevent, detect, and respond to foodborne disease outbreaks. This includes building national core capacities as required under the international health regulations, and facilitating rapid exchange of information through the International Food Safety Authorities Network, managed by FAO and WHO. Make safe, healthy food a priority. Take responsibility to ensure food safety. This will help your country maintain good health and achieve economic prosperity.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give their children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health.
What happened, Aiden? My mama told me I need to come off the tablets. Yes, you should. We need physical activity. Well, that's what adults say. Adults, I tell you. Seriously though, with physical activity, we will get better grades, better heart health, and improve the bone health. Oh, I heard it will improve memory and overall mood. Yes, it will maintain our weight and lowers the risk for the pressure. Do you know what will lower your risk of depression? What?
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
We're gonna get funky, 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 funky. Everybody clap your hands. Clap, 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 clap your hands. Clap, 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 clap your hands. All right, now, we're gonna do the basic step. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha, real smooth. Turn it out. To the left. Take it back now, y'all. One hop this time. Right foot, let's stomp. Left foot, let's stomp. Cha-cha now, y'all. Now it's time to get funky. To the right now. To the left. Take it back now, y'all. One hop this time. One hop this time. Right foot, 2 stumps. Left foot, 2 stumps. Slide to the left. Slide to the right. Crisscross. Crisscross. Cha-cha, real smooth. Let's go to work. To the left. Take it back now, y'all. 2 hops this time. 2 hops this time. Right foot, 2 stumps. Left foot, 2 stumps. Hands on your knees, hands on your knees. Get funky with it. Oh, yeah. Come on. Cha-cha now, y'all. Turn it out. To the left. Take it back now, y'all. 5 hops this time. Right foot, let's stomp. Left foot, let's stomp. Right foot again. Left foot again. Right foot, let's stomp.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Do your part to prevent mosquito breeding. Mosquitoes will breed in any container that holds water.
Tightly cover water storage containers such as drums, barrels, buckets and tanks. If this cannot be done, pour cooking oil on the water surface. Punch holes in all tins, plastics and beverage boxes to prevent the collection of water before disposal. Cover all tires or fill with dirt to prevent water collection. Scrub all vases once per week to remove mosquito eggs. Use mosquito repellents to protect yourself from mosquito bites. Dispose of garbage properly by placing in plastic bags and securing properly to prevent water collection.
A message from the Ministry of Health and Wellness.
Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Come pre this you, don't pre that. Let me tell you about the body and some physical facts. Physical activity defined as bodily movement. You know it beneficial to every student. Chin up, push up, jogging, sit up, feeling lazy. Better get up. Physical activity help your mood and memory, make you remember anything, cause it boosts dopamine and serotonin. Target attention, focus, regulate moods. Come learn something. Yeah man, listen young youth. Physical activity, healthier weight, go and exercise, students hold the faith. The more you do, the more calorie your body use. Calorie deficit, calorie get reduced. Exercise build your bone and make it more dense. A facts we attack, ladies and gents. Physical activity is of the essence, needed like full stop in any sentence. Come free this you, don't free that. Let me tell you about the body and some physical facts. Come free this you, don't free that.
During this time, with online schooling, we are sitting for too long. The problem with sitting for too long is that it leads to soreness, aches, and pains throughout our body.
One, two, three, two more. 1, 2. Adults to 30 minutes activity daily.
Good afternoon, everyone, and welcome to the afternoon session of our meeting today. I am pleased to introduce Dr. Nicole Dawkins-Wright. She is a committed healthcare specialist and public health practitioner who currently serves as a Senior Director for Emergency Disaster Management and Special Services Program. She's also the Branch Director at the Ministry of Health and Wellness. Dr. Dawkins-Wright contributes to nation building through direction of programmed activities that increases the resiliency of the health system in order to optimize healthcare delivery in emergency and disaster situations. She is the National Health Disaster Coordinator and, as I said, Director for the Health Emergency Operations Center and the Climate Change Focal Point System. Dr. Dawkins-Wright is a certified instructor for mass casualty management systems and the health aspect of disaster management in Jamaica. Her personal interests include family, spiritual well-being, and national development. At this time, please let me welcome Dr. Nicole Patricia Dawkins-Wright for her presentation. Doc?
Thank you very much, Dr. Lofami, and good afternoon, everyone. I'm very cognizant that I'm between your departure home, and we're also running behind, so I'm going to make this nice and tight. But let me first take the opportunity to thank all the planners and organizers for today's event for inviting me to participate and share on a subject area that I think is very important at this time, especially as we get into the aspect of the wellness component of the agenda. There's nothing that we can say that doesn't bring climate change into the conversation of wellness on the health agenda and marrying health and wellness together. So I believe is interesting to note that as we speak, we would have just completed an emergency meeting in respect of a new system developing that may affect our country in another 48 hours. And it tells you that this is the challenge that we face. It doesn't take much for climate and its impact on weather to affect our operations and therefore what we have to do in the context of health. And so, climate and health is such a wide and diverse area that I think organizers were very, very kind to me not to specify which way to go so I can zoom in on what I choose. And I do appreciate that. So as we share with our scientific community and our other participants and players in regards to the protection of health, promotion, and well-being in country. I have condensed the information into 3 general areas for general awareness of all players, the health implications of climate change, what has happened thus far so we can spatially locate ourselves in terms of what we do, either as researchers or as actors in the healthcare delivery system, and what we're doing within the health sector so that you can help us to support the response that we need to address the matters of climate change and health. And so a good place to start is to understand what our definition is. There is a standard definition by the United Nations Framework Convention on Climate Change, and I will read it, but where I want to land is an important part of it, which I will say, a change which is attributed directly or indirectly to human activity that alters the composition of global atmosphere in addition to the natural climate variability observed over comparable time periods. What is not explicitly stated in the definition is the matter of the time periods, because it is, in fact, the major issue, the fact that it's a long time period, and so sometimes, as persons and individuals, we undervalue the significance and importance of it because it's not so immediate. It is caused by rising emissions of carbon dioxide and other greenhouse gases, and what in effect happens, generally, a teaching moment, is that it traps heat on the atmosphere, rendering the earth warmer. That by itself is a challenge for health, but if that's not enough, the rising temperature could lead to other effects, the extreme weather conditions, which by themselves creates problem. But as we recognize, and we have come out earlier in presentations, the contributing factor to climate change, the greenhouse gas emissions, married to air pollution, is now seen to affect and impact almost every area of health and well-being and disease causation. It's almost hard to signify and identify any single area within the health and wellness and disease causation processes that is not going to be impacted by climate change. So wherever you stand, there's something of interest in the context of climate change. What is challenging is that the rapid climate change that we're seeing itself poses a direct risk, but it also affects other areas due to disruption in our health service delivery systems. And if we are not mindful and careful and use evidence and science to modify and improve on our health system and our health programs, we will be left behind in terms of our mandate to protect the health and well-being of the population. So according to the World Health Organization, we know from the perspective of what causes disease and what needs to factor in the context of preserving health and attaining wellness, we consider the determinants of health. Nothing in the determinants of health does not involve climate change. Be it air, clean air that we know, whether or not our drinking water is safe, the basic, and come down to the most fundamental aspects in the fight against NCDs, probably has to do with our dietary and nutritional standards, because the matter of the adequacy of our food systems to secure our health or allow us to recover from disease is also going to be affected. And if we have to guide persons for the protection of human health, if we're exposed to hazard, even the way we shelter people is going to be impacted by what climate change is doing to us. And it has been estimated that, as we've seen earlier, it's almost a runaway in terms of not just deaths, but potential life years lost. We are now realizing that an additional 250,000 additional deaths is likely to be anticipated unless we take serious steps in the next 20 years. We are in 2023, between 2030 to 2050, an additional set of persons are likely to die because of the impacts of climate change. That picture on the right is just taken to show that we can pocket it and choose our color and decide what we want to do, or we choose our profession. There's something for climate change for you. It is important for us to realize, though, that if we're going from the public health perspective in the context of protecting health and abating and mitigating disease, we have to recognize that climate change is a threat multiplier. So if we identify any risk, chances are climate change is augmenting that risk for whatever reason. If we find that there are protective factors, climate change is likely to diminish the impact and the effect of these interventions if we don't account for it in our measures. So we have to understand the science behind it and allow it to infiltrate through whatever mechanisms we plan to incorporate into our measures. It affects all aspects of health, whether it be physical or mental. And if we go from the community perspective, there are community health assessments that are going to be altered based on various parameters related to climate change. If you take nothing else from what I say today, I want you to take a note of the picture that the WHO Powerhouse produced for us. It's a very broad area, but if you can remember that picture, it tells you just about everything you need to know, whether you are on the receiving side or the impact of being affected by climate change, or you are the professional or the researcher to see what is happening in the context of climate change. It's a nice summary, fits in your pocket, and if we need to swell on it, we can add to it the scientific data. The vulnerability factors have been clearly identified in terms of demographics. We know who's going to be worsened. The matter of equity is an important topic for discussion, and equity features very prominently, or the lack thereof, in the conversation of climate change in relation to the health and wellness agenda. There are also exposure pathways that are going to be worsened because of our climate factors. And from where we sit in terms of our health provision and health service delivery, we have to change. And it's not a little change. It's a transformational change that's going to be required. Now, what does that look like? Let's think about it. If you consider, for example, that we are trying to amend and guide persons, we have several commercials looking in terms of our sugar content and the nutritional value of our food. What climate change is doing is saying to us is that what we thought we knew, we may have to change that knowledge. So the body of knowledge that's currently available is going to need to be improved and enhanced in very short order, because the nutritional content, wherever you sit, is going to change because of climate change, because of the change in weather that we see. If we look in terms of what we thought or understood to be the burden of disease, zoonotic disease, that's also likely to change. We have a model to address and mitigate the causation of zoonotic diseases. That's likely to change. Climate-sensitive diseases are occurring in territories and countries that they never used to occur before. So we can't use geographic separation to distinguish the likelihood of diseases. And even though we may have profiled our disease pattern in country, it is likely that within the next decade, what we thought we expect and projected is likely to be significantly altered. It therefore means that as we talk about establishing our research agenda, we may have to adjust it and update the research information that we have a lot more frequently in order to better inform what it is that we need to do. So whilst we are running away and dealing with NCDs, our presenter earlier spoke to the matter of what's causing death in our younger persons, even that is going to change. The injury profile of our country is going to be affected. Our transportation sector is going to be impacted by the effects of climate change. It therefore means that if persons are becoming injured and are dying from patterns or designs of our transportation system, when we adjust it, by the time we catch up with the changes, we're going to have to change again. Otherwise, we're going to lose more life years again related to that, unless we factor it in our long-term planning. We spoke in terms of our players and our partners in health. Nowhere is it more emphasized that if we're going to address the issues and the multiplication of threats and factors related to climate change, that we have to be a lot more diplomatic and social in partnering for health because of the impact it's going to have. Many persons outside of the health sector are not very aware of how significantly linked the climate change and the weather impacts are on the disease causation. And so we are going to have to be able to empower ourselves to better guide our partners in health in terms of what we need to do to protect health. It's not just a matter of the actual food in and of itself. There are several studies on the global stage that is showing For example, that even at the elemental level, in terms of nutritional contents and vital elements that need to be in our food sources, are already dwindling. Dwindling in terms of those that are necessary, and those that are harmful are increasing. Is that the same pattern that we're having in Jamaica? The evidence suggests that it's not necessarily so. We can't simply translate the information from one geographic domain into ours. We are looking in terms of our fishing population and our fisheries. Even that area is significantly affected because of the changes related to the ocean patterns and the contents within water in terms of the value and the potential risk that our aquaculture will face. We don't have to go far. Whilst we may be a little bit slow in producing the absolute scientific data to support it, our farmers are already telling us that there is a problem. In a recent survey done earlier this year amongst farmers in the parish of St. Elizabeth, they have indicated that not only are they already experiencing the impact of weather, but they have already realized that their food quality is less. Smaller yield, their animals at maturity are lighter, and therefore the nutritional value of that protein is less. They are now facing new pests. Do we have to contend with that? And what they do to manage, and they're seeing new diseases which they're never familiar with. And what that means is that they're going to be incorporation of more and more diverse use of chemicals to manage their agriculture and their outputs. That is something we will also need to factor in the consideration as to what we inform our persons going forward. We talk about our programs. Let's take one that's very, very close and we're very good at, our food safety program. What we guide persons on in terms of food safety provisions may need to be changed. Either because how we manage in terms of where people are and how they gather foods will have to be guided, but in terms of our monitoring provisions, our water safety provisions, people will take chances. And so our water and sanitation practices will also need to be adjusted. So our standards and our monitoring and evaluation framework would also need to be updated just because of that. We go into the matter of who we are considering. Whilst we have defined vulnerable populations in our country and recognize that children are very special in the context of vulnerable population, it is even more so in the context of climate change. And when we add on to that the social status of individuals and where they are socioeconomically, because some persons will be able to do better. So whilst we can guide some persons to adapt and adjust to the impacts that's likely to happen, some persons will be far worse off. And so we have to do a lot more for our children who, by the time this is fully impacted, we may be gone. And they will resent us if we haven't done enough at this time. So if it's not clear, what I'm saying is this is an urgent issue that we need to address where we are so that our next generation can benefit from the impact that we're going to provide through evidence in terms of adjusting what we are preparing for in terms of health outcomes, wherever we are. I've spoken about the matter of vectors and where they are, and this is already showing in terms of projections, things like dengue, we're dealing with dengue outbreak now, is showing up in countries who never knew anything about dengue before. And yet our population is moving the global, we're shrinking. So persons that are exposed from areas of international travel becomes more significant in terms of how we're going to, for example, decide and determine whether or not the travel history is associated with certain patterns. What we never used to think about, we will certainly have to think about because diseases are showing up in territories that they never used to occur in before. So what are we talking about? The transition. What does that look like? In simple terms or in the language, it says a climate resilient health system. Now, you talk to anybody, they use the term, but not necessarily everybody knows what that means. It's an easy term to use, and globally we know what it is. We speak to, for example, buildings that are resilient to severe weather, but climate resilient health system speaks to, are we now better able to manage the increased burden from climate sensitive diseases? Are our healthcare workers sensitized and aware? Are they in a better position to guide the patients and clients that they have. So if we think only in terms of infrastructure, we forget the most important element, which is our healthcare workers. Are we adequately preparing our health workforce to deal with the changing in the health profile that we're likely to have? And that's something that we need to consider. So whilst we are protecting and promoting through encouraging, for example, green spaces and active transportation and air quality improvements, there are other things that we need to do. When we engage, for example, with our health managers and our directors and our executive team members, is it clear to everyone that the health sector is a major contributor to climate change conditions? It has been clearly shown that the health sector contributes as much as 5% in terms of emissions, and therefore we have a duty to ensure that we model the behavior that we expect other persons to do. Are we good ambassadors in that regard? It has already been shown as well that just by the basic services we provide, the consumption of energy is 2.5 times more than probably any other sector. So as players, we recognize that we have a huge responsibility in terms of being friendly to the environment, modeling the behavior that we want, and what we need to do in terms of being ensured that we don't worsen our disease pattern. And we can't just react. It is not sensible to do so. But apart from it not being sensible, we may miss opportunities at this time to improve, to provide for the patients that we care for. Some things are irreversible, and there's evidence to suggest that some things are already reached that point. Can we do it? No, is a question that needs to be asked. So in Jamaica, we have adopted a model. In Jamaica, this is not something that any one country can do. We know that. So there's a regional approach. But even within our own borders, we recognize that there are individual things that we must do. Because as I mentioned earlier, what is good next door is not necessarily effective over here. And so we have to tailor those recommendations to our context. Do we have the data and evidence to do that, to design that, to inform that? At present, there's insufficient. There's some data, generally, but if we drill down, it's a little bit more difficult to find. Whilst we can have general data, we have started in terms of what happens on the national level. Our planning institutes, our major organization in country, the Climate Change Division of the Ministry of Economic Growth and Job Creation, has provided a framework to guide these activities. And what is important is that it identified 6 sectors that are priority for urgent and significant action. And guess what? Health is one of those 6 sectors, and we have to move. And so we're doing our part. There's a framework to guide us. We know where we are. Recognizing that we're such a significant energy utilizer, we also have to realize that we have a part to play in what Jamaica has committed to in terms of the national determined contribution to reduce emissions in country. And we know what that is. We are committed on the global level to the Paris Agreement, and health sector has a part to play. So it is within that context that we as a health system are trying to get information to inform how that would look like and what needs to be done. Tools are available. We need to customize them for our use. Where are we? There is enough data on the national scale. Can we carry it down to the local community level? So whilst we can look in terms of emissions from our health facilities, can we also partner with our communities and our neighbors next door to help to contribute for the impact? Because if we do it within the health system and next door is not doing it, chances are our impact is not going to be fully effective. So we also have to take a community health approach to the actions that we try in health. So it's underscoring the importance of partnerships. If we look also in terms of where we are, we're committed to that. The concept of adaptation as a cross-cutting element is where we go, is of particular relevance to health. So while all areas and all sectors are working on it, we now need to see how this is going to be measured in terms of the adaptation, not just from health sector. Others are doing tourism, etc. Can we assist the whole system in being able to provide the evidence to support the interventions. Because whilst everybody recognizes climate change as an issue, it's still a challenge because we need evidence. It's very hard to do anything with climate change and action without evidence. And that's what we're speaking to. Recognizing the importance of what this may be in terms of emissions, it is interesting to note that 7 high-impact actions were identified at the global level. And if you can see the picture well enough, 5 of those are health-related. 5 of 7 on the global level. We have a lot of work to do. What is standing out again is that how pervasive the matter of food and our food systems is to this conversation. But we'll highlight the matter of the use of renewable energy. We speak to the matter of logistics and our supply chain management. It speaks to the recommendation for drugs, where they're coming from, are they produced more effectively? Can we, again, do more in that regard at the local level? And so I'm coming to the end of it just to show you something that we recognize, that we are making some progress. We started some time ago, almost a decade ago, and we have been working with our international partners in terms of how to do so. So there's a climate change and health survey, for example. At least 2 have been published, and the 3rd one is due to be published in a few weeks or a few months. And so that can inform some of the activities that need to be done, a lot more intense. We also have a Caribbean action plan for which Jamaica is a major player in terms of what needs to happen. And on that action plan, there are 4 strategic lines, and the first one is on evidence. And unfortunately, we had to report again that the available evidence at the local level is still limited in that regard. And so there's still a general conversation about what we need to do. But again, we are leveraging the partnerships to build out through consultancy with our international partners, of which the most significant is the European Union and the Pan American Health Organization. There is a metric that can be used. Whilst this is just a pictogram, there are also very standardized tools that can be utilized in terms of designing the evidence-generating mechanisms to support the interventions in country that speak to what a climate-resilient health system is. And again, this speaks to not just the building, the healthcare workers, and our health profile. That's what we're talking about. And the impact is going to be realized if we increase on a level of areas for intervention. And one of the key areas, again, we spoke to the matter of awareness building. We did a study in country. This was 4 months ago. And it's very interesting to note that as many as 90% of our healthcare workers said we're still unaware of what it means, what climate change means, what climate impacts mean, and what it means that we're supposed to do, which is of grave concern when it's almost been a decade that we've been acting very vociferously. So the evidence is showing that we have more work to do, because if our healthcare workers are unaware, then they are less able to provide the guidance that's necessary for the clients, the patients that they see, if they're not aware as to what we need to look to. If you ask a patient in the same study amongst the farmers, they themselves said that they did not speak to the healthcare worker about concerns related to climate because they themselves, when they asked, they couldn't get enough guidance to tell them what is important. This is our population. And so there's a lot that has been done. We spoke about the work that we're doing with our health facilities to render it more resilient. And it is something to applaud. Jamaica is one of 60 countries, one of the first, to commit to action in terms of our climate-resilient health system for a low-carbon mechanism. And we're looking towards it. There's a lot of capacity that has been built. And so there is a foundation, a framework within which we can, in fact, change this pattern in terms of the level of awareness in country and the implications for health. At present, there's a suggestion that the research focus should be on cancers and food safety and NCDs from the lens of climate change, but there's also strong need, a greater need for the technologies around the matter of air pollution and its relationship to health, and one that we have very, very little information on, not just here, generally speaking, but we certainly need it, and the matter of heat stress and health information systems, because there's a matter of metric that we have not yet addressed, and we need to be able to modify and upgrade our health systems and our health program so that they can be classified as climate informed. That is my last slide, I believe, and so I think I've stayed within my time frame. Thank you very much.
Thank you very much, Dr. Dawkins-Wright, for an excellent presentation. Very informative, as usual, and very detailed. At this time, I am going to invite persons from the group if they have any questions, comments for Dr. Dawkins-Wright. I'm not seeing anyone with their hand raised.
Okay, thank you. We're in the physical space, so probably you wouldn't be seeing us. Thank you, Dr. Wright, for a very excellent presentation. And I was wondering when you were presenting how we as a nation could help ourselves based on the simple methodology of tree planting, allowing our environment to be enhanced, even within the hospital environment, where you say some 5% contributes to the carbon emission and all of that, and our homes, our dwelling places, instead of the very high-rise building where you can't have any planting, no floor, no sand, you know. So how do we as a nation do the little bit we can do to combat?
Thank you for that question. And the truth is we do have guidance for that. And generally speaking, the guidance, we tend to do it from a local level. So there are models. For example, we can, or climate-informed healthcare workers can guide persons when they encounter them as to what they can do in their homes when they modify in terms of their living conditions or food systems. And certainly, again, within the health systems, or Mrs. Hunter-Jones is right here, but for example, we're looking in terms of interventions related to vector control in the context of environmental health and climate change. That is also being done, and we put that plasma on there, and there's a model for that. We are also, I didn't say it just yet because I don't want to preempt it, but there's also work going on in terms of a policy for redesigning or upgrading or retrofitting our health facilities so that they are more eco-friendly. So we have started it. There are models produced by the project with PAHO for what we call a smart healthcare facility, and there's a metric for it to retrofit it in the context of making it greener or more environmentally friendly, green spaces. There are also models. We work with environmental health team, works with the National Environmental Protection Agency, NEPA, in terms of the community interventions for green spacing. Right now, we are building capacity to be able to measure the extent of green spacing and air quality in the immediate air. And within another year or so, we anticipate that those will also be rolled out. So there are things that we currently have. A lot of groundwork had to be laid in order to better inform, again, under the theme of almost individual responsibility. There are capacities and processes and tools that we currently have in our immediate employ that we can inform at the local level. So there are ways to do it, and it usually has to be tailored.
Thank you, Dr. Dawkins-Wright. Wonderful presentation.
Thank you.
And I look forward to our smart health facilities because we need to be more resilient considering the changes that are happening and what we are anticipating that will come with those changes. However, for now, I know that will take some time because it's not an immediate fix. But for now, one of the things I think we need to be looking at as healthcare workers, how do we help our staff or healthcare workers to adapt to the changes now within the workspace, especially those who have to go on the field every day in this heat and sun and the impact of that on them. And I think it's something we need to seriously look at, even within the workspaces, within the facilities. How do we have water available? Simple things. Do we have water readily available for our staff? And other things like that. How do we adapt even with our clothing, you know, as healthcare workers, to make us more comfortable in the workspace? And so we need to, as healthcare, look at our healthcare workers and how we help our people to adapt to the changes while we adapt the workspaces.
I thank you very much for that. And I do that because under the same project, we're just completing at December here, the Smart Healthcare Facilities Project. It spoke to what needs to happen at the facility level. And so part of being rated as the metric that we use is an A70 rating. A facility that has been assessed as A70 has a few components in there. One of those components speak to what we do for healthcare workers in terms of increasing their awareness, how we render the working environment more adapted to the current situation, and as a matter of being able to function in relation to water, and the HR considerations that need to happen. You spoke about the uniforms. Yes, that is part of the conversation, and so that dialogue goes on in terms of what are the standards in ensuring that persons are comfortable, which is also one of the metrics under the A70 rating. So right now there are 4 facilities that reach that rating. It is done to training for the staff at the facility level. Because again, as you say, what works in St. Elizabeth may not work in St. Andrew. And because of the design differences and because of the various climate zones that we have in country. So we have to tailor it locally. So there is a generic guide, and then we adapt it when we do that A70 training. So the policy will come, the training is part of it, and the actual measurement in terms of being able to function independently, either because of water shortage or because of severe weather, is also part of the A70 rating.
I am so happy to hear that, Doc. And awesome. Another thing that we need to look at too is how do we seal those buildings that only have, you look up and you see zinc.
Yeah.
And when the heat bears down on it, it bears down on the staff as well. And I think that is something that's an easy fix. We don't have to wait on the smart health facility fixes to fix that.
So I would have mentioned the smart healthcare facility policy that we are working on. That is coming under the health facilities maintenance program. And you heard Minister mention earlier in terms of the investment with regards to retrofitting and upgrading our facilities. It does, in fact, speak to that as a requirement. Not as an addition or an extra, it's a requirement in terms of the investment to be done in terms of retrofitting. So it is to be done on a much larger scale. But again, what was being worked on was the laying of the groundwork and the guidance, which has now been produced and tailored and adapted for our local. So the zincs should certainly go in short order as a part of the improvement in our health systems going forward. Good.
There are no further questions or comments for...
There's one more.
One more? Go ahead.
Many thanks for such an excellent presentation, Dr. Dawkins, right?
Thank you.
And I really hope that the way forward as recommendations that you had put to the table will actually be realized. I have a question, however, concerning costing in terms of climate change, the impact on our health systems from a micro and macroeconomic perspective. If there are any plans or one could consider for future. Because if it is that we are going to, as you had said, tailor our health program to fit climate change, we need to know what we are getting ourselves into. This is a must. This is something that we must do. Mm-hmm. But at the same time, we need to know what kind of costing it would take in order for us to make sound policy decision-making and possible strengthen our research, policy, and program interface. We also need to probably have a sensitization campaign, which, because as you said, the healthcare, quite a number of healthcare providers not seeing the link. It's not just healthcare providers.
It's general.
It's general. If persons can know that, look, when you do simple things, and this is not simple, but they think it's simple, burning garbage in their backyard or at the side of the street, just for the sake of burning garbage, it affects not just the environment in terms of pollution, but it also causes persons to have respiratory issues, right? So how do we get persons on board as a country to change their mindset? As you heard the minister spoke this morning about changing of the mindset so that we can garner fruition in the kind of research that we put forward. So I'm looking forward to that, and thank you so much again. It was really timely presentation, and it's very, very good. Thank you. Over.
Thank you very much. I think Peter Gay is still here. Yes, she would have shared with me in a session we had earlier on this year in terms of a tailored program at the local level and what can be done. Because like most things, anything health alone can't do it. So we modeled a partnership arrangement in terms of improving our better adaptation measures at the community level. In terms of what needs to happen. So the guidance, the health promotion and education sessions, factoring the climate consideration. So that came under one of the projects to morph or modify what we had thought was an adequate climate awareness program, which clearly is not as impactful as we thought it was. And so we need to adjust. On the matter of the economics, yes, our team members in the Policy and Planning Division, we have had that conversation, and there is a discussion surrounding the cost implications. One of the tools that we managed to acquire with the project with our colleagues at the Planning Institute of Jamaica under the pilot program for climate resilience is a costing tool in terms of what the retrofit may look like for an A70 facility. So we have the tool in place to be able to cost it and put the dollars and cents on it from the health facility perspective, and the health impact assessment related to transforming our health system. A much broader picture is also being discussed with our health economics team, and to see how can we afford it. Because it's not an if, it's what we're going to need to do, because it is an investment.
Yes, so I just want to add to the congratulations, Dr. Dawkins, right? It was really an excellent presentation. And I am seeing many persons reflecting same in the chat.
I appreciate that.
So the question that I had in listening was, we know the global initiative. I was wondering about the local initiative. So for our Vision 2030, National Development Plan, because so much of what we do in terms of our operational plan and strategic business plan is linked to Vision 2030. So I was wondering, what is in it? Is it adequate? Are we ahead, behind? Is it something that we have to relook in terms of what is focused in the Vision 2030? So I just wanted to get your feedback with respect to that.
Thank you very much for that one. And as mentioned, the policy framework and the National Development Agenda specifically identified this as an issue and identified the health sector and the health component of that action as a priority to be undertaken. And the sector plan that we have, goal number 6, also speaks to the matter of climate-informed improvements that we need to have. What has been the challenge is that it needs to be guided. So Jamaica as a country took a phased approach. So the broader encompassing generally across the country, and now we are working to build out the elements for the sector or the subnational elements of it for each sector. So this is an opportune time to actually look into it to see how it can be done. There is insufficient data, to be honest, at the local level, but we do have some data that we can use. And so that is what has been in the work. And admittedly had been a bit of a challenge in terms of informing some of the changes. And so to the first part of your question, are we behind? We are a bit behind. Right? But, God is an on-time God, so we are talking about it now, and so it needs to happen. We have 7 years to the 2030 timeline. Can we do all that we wanted to do by 2030? Honestly, no, but we can do some. And I believe that's what we need to do. And if we can get the mindset change, the conversation about mindset and behavior change, I think we are well on our way, because I think that is the bigger part. The point was raised in terms of what people do in their individual spaces. If we can achieve that and deal with the matter of air quality, for example, and the matter of mobility, that's a far way in terms of our health outcomes and in terms of the health service delivery mechanism. As Minister pointed out, there's a lot of investment for the first time since 1962. Can we leverage some of that to reach to the infrastructure and the system design standards that reflects a climate smart system?
Just one more thing under the matter of costing. We could probably also look at the disability adjusted life years lost.
Yes.
When it comes to climate change, because a lot persons have been affected, for us to make sound policy decisions again.
Yes.
Thanks.
Yes, for sure. Thank you.
There is a question online, and I'm just trying, it says, what is the role of infection control in climate change?
Significant role. So whilst we generally, again, because we tend to focus, because of the priority in terms of NCDs, the matter of communicable disease is critical, and it's an important component of it, and it is one of the action areas for intervention in the context of climate change. So because, again, it's pervasive, thank you, I'm hoping you're still hearing me, but there is a role to play, and we can tailor it along the lines of what our focus area is. Thank you. Thank you very much.
Thank you, Dr. Dawkins-Wright. I see that Nurse Shirley Hibbert has her hand up as well. Nurse Hibbert?
That is online.
She raised her hand. Oh, no, she has taken it down.
Okay. All right, thank you. Thank you very much.
Thank you, Dr. Dawkins-Wright. Thank you so much.
Dr. Dawkins-Wright, thank you for excellent presentation. I don't use those words very lightly.
I know, you see me blushing here?
But we really appreciate it, and this is for you, a little token. Thank you.
Thank you.
Hi, good afternoon. Welcome back. And now we're going to have conference fun and giveaway. And now I have 4 questions for you. As you know, we're celebrating our 14th year. So we have 4 questions this afternoon. You're going to give these answers via text. You're going to text the number 344-3204. As I said, I'll repeat, you're going to text your answers to, so this is for everybody online, 344-3204. So the first question is, please give 3 themes under which abstracts were accepted for NHRC 2023. Question number 1. So please indicate which question you're answering. So question number 1. Give 3 themes under which abstracts were accepted for NHRC 2023. Question number 2. How many panel discussions will we have for NHRC 2023? Question number 2. How many panel discussions will we have for NHRC 2023? Question number 3 comes to us from Dr. Irvin Mackenzie's presentation. That's feature presentation number 1. He gave us some statistics, and for this question we're asking, what is the prevalence of periodontal diseases in people 15 years and over in Jamaica? Question number 3 is, what is the prevalence of periodontal diseases in people 15 years and over? And the final question, ladies and gentlemen, what was the theme for NHRC in 2021? Question number 4, what was the theme for NHRC in 2021? So please text your answers to 344-3204. That was it for conference fun and giveaway. Looking forward to receiving those answers, and we will inform you how you can collect your prizes once you send in your answers. Thank you.
So we thank Mrs. Mullings for highlighting those questions, and we encourage you to text your answers as indicated in the chat for prizes and surprises. We have come to the end of a very full day of excellent presentations. We began with our opening ceremony, where we heard that meetings such as this create the opportunity for reflection, and that everyone has a role to play in the health and wellness of the populace. We also heard that we will likely have to join behavioral with clinical research, and there needs to be an emphasis on change management. We had 2 feature presentations, one on oral health and NCDs, where we heard that oral health has been overlooked for far too long on the global health agenda. And we also had our recent presentation on climate change and health, which generated so much discussion and emphasized the health impacts of climate change on health, managing climate-sensitive health risks, and adequately preparing our workforce to respond, as well as awareness building. We also had sessions on NCDs and patient knowledge and care, and we thank those presenters for the high standard of the presentations. We invite you to join us tomorrow, where we will begin with a special presentation by our permanent secretary, followed by special presentations on the applications of technology in public health. We encourage you to remember to explore the virtual space, as there will be prizes and surprises for persons who are on the leaderboard for clicking and exploring the spaces the most. Most of all, we want to give thanks for a very good day, and we encourage you to have a good evening. Remember, please join us tomorrow for a continuation of the conference. Thank you and goodbye.